demarcation. You'll see in the images, basically you have the members and labyrinth is called, and the members labyrinth within them are ducts. Per this picture have the APs which we saw have the round bit. Which part of the per one? Per one. Round bit. Other important parts are that which is going to have the central. This is called as the what is spiral lamina. They do, they divide cochlea, vestibular. Right? There is also duct. This is the anatomy following terms of the spiral lamina. You can see maybe you can see the spiral lamina, vestibuli and very well. Circular anatomy. I'll just spend a time on the now when what part can be seen on very nicely. Internal part of and the canal. There because there is all fluid background. Here there is CSF, there is CSF here. You can see those very nice. Up to as they get into the Petrous, they get into the cochlea and but that MR is the only thing. Keep tracing it, but use it as CT. See those. All that you can see the cobra eyes. Cobra eyes was yellow. Have labyrinthine portion. Then there is a genu. It's called as an anterior genu. After which this facial nerve takes an acute return right behind. It's called as the tympanic segment. Coronal section. I see the labyrinth cut on the snake. Important thing about the genu is GSPS runs or is given off zoomed out image have the coronal and the genu GSPS acute post fine. After that, at the level where it goes next to sinus, there it's an abrupt turn down and it's called posterior. Mastoid have cisternal segment, have a canalicular segment, tonal segment, have a canal segment, have a labyrinthine, have a tympanic, more comfort level. So now we try and exercise whatever part is easy. Instead of going to over, if I tell you that this most section, what is this? Wait. So, guys, that's the canal which is being cut. I coronal. Now I am seeing. He will jump the gun and say, I see a Petrous. What is it? Tell me what vestibular or is it subaquate? See one small little which is running towards the superior. That you will see on the best image. Really good. You will see both the canals very well. Not everyone is looking for it, but it is good to know. And the reason why you should be able to identify is you should not mistake it for a fracture. If a patient with trauma comes to you, when you see this tiny lucency, you should not think that there is a fracture. This is a normal area where the subaquate canal runs. Okay, now I go slightly below. I still see the IIC, and now I don't know what's happening here, but I would love to see the labyrinthine segment of the facial nerve, but I'm not very comfortable yet. I'm still seeing the semicircular canals, right? This is your mastoid, everything we've been able to identify, that's your Petrous. Now I see, this is my IAC, this is the brain, this is the CP angle cistern somewhere here, and from here I see that this is the IAC, and now I see this part I can see. What is this? This is the labyrinthine segment of the facial nerve. And then I am seeing, this is where probably the genu will come in the next image. Okay? And now I am seeing little bit of the vestibule appearing. This is a part of the cochlea. I told you cochlea will always be seen medial to vestibule. This is the vestibule. IC will always be seen between the cochlea and the vestibule. You will always see it. This is the default signature. So here you have part of the vestibule. These are the semicircular canals here. Which canal is this? Okay, you will just go on seeing it as we keep going down. So the topmost was the superior semicircular canal. Then you will, as you go posteriorly, you will see posterior, and then you will see a limb of this, which is nothing but the lateral semicircular canal. Okay, so we will go down now. Now, if I told you that this was a facial nerve going anteriorly, this facial nerve came behind now. This is the tympanic segment of the facial nerve. Okay, I got to see the ice cream cone, Prusac space. That was the apical turn of the cochlea, middle turn of the cochlea. What is this? Cochlear aperture. This bone density which you are seeing is the modulus. And then you can see slight bony things in between, which is nothing but the spiral lamina. Alright, so again additus, antrum, mastoid air cells. Everything you are able to identify. This is the lateral semicircular canal which is coming in its entirety. That was the posterior semicircular canal which you have just about lost now. Upar jo tha. Now I am coming further down. I am seeing the cochlear aperture even better. I am seeing the modulus even better. That is your apical turn, middle turn of the cochlea. This is the carotid artery. That's your eustachian tube. Now, this is like a partial volume between the facial nerve and the canal for tensor tympani. But here I would still like to believe that this is the facial nerve. This thing out here. Again, the ice cream cone. Radiologists love the ice cream cone. Prusac space, additus ad antrum, and the antral cell, mastoid antrum. Okay, fine, fine, fine. I'll stop. Oh, I'll finish it in the next. You can give me 5 minutes. All right. All right. So we'll have to just do a little quickly now. So that if that was your cochlea, what is this? Vestibule. This is part of your lateral semicircular canal. And okay, we'll go further down now. Now I see again the cochlea, apical, middle, basal turn just about coming. I can't see the round window niche, but I can see the oval window. This is the vestibule. This is the lateral semicircular canal. Do you want to tell me what structure is this? This is the vestibular aqueduct. It is always seen running perpendicular to the IAC. And you can keep appreciating the carotid eustachian and the canal for tensor tympani. You can actually see this is the canal for tensor tympani. You can kind of see some muscle coming here. At the level of the cochlea, the promontory, it will turn and go and insert onto the malleus. Right? So that's your tensor tympani. That's your malleus, incus, stapes. Basal turn, middle turn, apical turn. This is your posterior semicircular canal. This is your vestibular aqueduct. It should not be more than posterior semicircular canal. If it becomes thicker than the posterior semicircular canal, it is a dilated vestibular aqueduct. Further down, I see the carotid, eustachian, tensor tympani. I see my ossicles. I see now the basal turn, and I see this air pocket in what we call is the round window niche. Okay. Then I see the vestibular aqueduct, part of the posterior semicircular canal, my W, everything. Are you all able to identify? Great. And now this featureless thing, as I always tell, that's your carotid, tubular. That was axial. Now we come to the coronal. We'll go anterior to. I'm seeing a vascular canal, carotid. I'm seeing this structure. This is actually the canal for tensor tympani. This thick thing can only be a muscle. It is not the nerve. And just above that, you will start seeing this is middle ear that going behind. I start seeing the ossicles here. I see the cochlea is just about going to. This is the tensor tympani. This is the tympanic membrane. External ear, middle ear. We saw this image. Head of the malleus. Malleus going to articulate with the tympanic membrane at the umbo. Now I am seeing some structure coming here. This is the continuation. This is this structure. This is this. Divides it. This. Divides it. This. All right, great. So this was about the CT, and I'm going to just quickly run you through the MR images. See how nice and delicate and dainty MR images look. So that's your basal turn of the cochlea with the spiral lamina in between. Again, the basal turn with the spiral lamina, scala vestibuli, tympani. What is this? It was about the CT, and I'm going to just quickly run the posterior semicircular. See how nice the vestibular aqueduct will come slightly more. Abhi vestibular basal turn of the cochlea with the spiral lamina in between. Again, the vestibular posterior semicircular canal, cochlea, middle turn. What is this? Apical turn. Every time you are seeing that line inside it, which is nothing but the spiral lamina. Further up, and you're seeing the cochlea again, all the turns of the cochlea really well. This canal is just about going away, the posterior semicircular canal. IAC has come. This is probably the region where the cochlear aperture will come here. That is the dark thing on MR is the modulus. Just below that, this is nothing but the cochlear aperture. Always look for the aperture on CT as well as MRI. These are the nerves running inside it. That's your vestibule. That's your lateral semicircular canal. I don't have the vestibular aqueduct for you, but that is definitely the posterior semicircular canal. Okay, you will sometimes, it is all right sometimes not to see the vestibular aqueduct. It's all right. Kuch nahi hoga. Only thing is when it becomes really dilated, you're worried. But otherwise, it's okay. It should just be the dimension of the posterior semicircular canal. So that is your lateral semicircular canal. And as you keep coming up, that is your superior semicircular canal. And I'm going to just show you this one image here. This is what we always do when we are looking for cochlear implants, that we cut the section like this. We take it perpendicular to the IAC. So we do like an oblique sagittal image. If you keep cutting it like this, there is an anterior portion and a posterior portion. So anteriorly lies, antero-superior is the facial nerve, antero-inferior is the cochlear nerve, postero-superior is the superior vestibular nerve, and postero-inferior is the inferior vestibular nerve. Sometimes you can see this branch of the facial nerve going along with it, the nervus intermedius, but suffice here to say that you should be seeing 1, 2, 3, 4. And that's exactly what you're seeing. 7 up, they call it 7 up, 8 down. So facial nerve, cochlear nerve, superior vestibular nerve, inferior vestibular nerve. This is the signature of the IAC. And I'm going to just leave you with this Stenvers and Poschels. There used to be sometimes when I used to be asked for cochlear duct length, but now nobody's really asking me for it. It is about 35 mm, we all know, 34 to 35 it goes. But this is the view in which we calculate we draw a line. There's a formula for it. I haven't included it here, but just to show you the views, this is how beautifully Stenvers will show you the entire cochlea opening here. What is this? Basal turn leads to the round window. That is your round window. And then we will always do this to look for I think I labeled it wrongly, right? It should be Poschels and Stenvers opposite. So you have this semicircular canal. Whenever you're suspecting a semicircular canal dehiscence, this is the view that we will do. We'll do the Stenvers to see if there is any dehiscence of the, please excuse my labeling. Yeah, Poschels is for semicircular canal. Yeah, I always get confused. I like to only do it in that way. That's it. This is the view that we want. So you have the superior semicircular canal if there is a dehiscence of the superior semicircular canal. Sorry? Oh, okay. All right. Here. Then this picture that you are seeing. Is this what you're saying?
Hello?
No, you're not seeing the IAC actually in this. Okay. No,
Hello?
but this, I should show you better here.
Good morning.
Okay, I think we'll have to. So anyway, so that is what this talk was about. I'm so sorry I took extra 2-3 minutes, But I hope that we've managed to do a little bit of axial and coronal anatomy. Thank you very much for your attention. And you can connect with me on any of these three things if there is any need, any time for anything in ENT radiology. Thank you so much. Thank you.
Hello, good morning. Are you getting my voice? Someone should respond there.
Hello.
Hello.
Yes, sir, we can hear you.
I'm not getting your voice. Please
Hello?
speak loudly.
Hello.
కెమెరా రావట్లేదండి.
Hello.
Hello?
కెమెరా రావట్లా.
Some people who are window. For that, to achieve that area, we have to keep the baby in a proper position. Usually, we'll take the baby along with any of the parent to avoid the separation anxiety. And after keeping the baby on the table, we have to take the baby to the as much as possible to the edge of the table. Take the edge of the table to have the access. And also here, you should remember the positions. There are 3 positions for the neck. And also one more thing, the proportion of the head of the baby is more than the body of the baby. To achieve the neutral position, we have to keep the shoulder below, like while doing the tonsillectomy in rose position. Here also I will explain 3 movements. These are the flexion, extension, rotation, and also the tilt. The tilt is called. How to make the neutral position of the head to achieve the proper mastoidectomy? We have to keep the shoulder pillow below the 2 shoulder blades, extending from both sides equally, and also keeping a round, this is a ring, the ring made from the tenicoid ring. See, now we have achieved the parallel to the body. Are you able to understand? Just please interrupt whenever you want to have any doubt. Please ask me something, otherwise I will go as a super fast express. Please stop me wherever you want to have the detailed explanation. This is the neutral position. We have achieved the neutral position by placing the baby tilt and also the extension and rotation towards the opposite side of the surgery. Then this is the position of the baby. Are you got everything clear?
It's clear, sir. Dr. Sampurna here.
Then
Sir, it's clear.
Now I will make some infiltration, even though we are doing under general anesthesia, to have the adequate vasoconstriction to prevent the blood loss. Even the minor volumes of the blood loss will cause the hemodynamic changes in the pediatric age group. That's why you have to utmost care to prevent the blood loss. You can forget everything, previous issues and all, just follow me. How easier to do the cochlear implantation. My life better, easier made by Santosh and Dr. Varsha Joshi by explaining everything, the anatomy and also the other requisites for the cochlear implantation. Clearly I will focus on the surgical issues only, starting from the position of the baby. Now I have making a proper position and doing the infiltration. See my infiltration technique. Sterilium. I will usually do with the infiltration with my bare hands to have the palpatory sense. where I'm infiltrating, how to infiltrating. The technique is also very simpler. We shouldn't use the multiple pokes of the skin to enter the infection into the deeper areas. That's why always we have to do a single poke technique. For this, I will prepare the solution, and also before that, you should know the markings. Already Santosh explained, even though I will explain something. Metal. Here, for the juniors, for understanding sake, I am showing these markings. Already he explained everything. Here you have the horizontal orbitometer line, and also for this we have to make a 45-degree line only, where you can see the parietal protuberance and also the occipital and mastoid protuberance. Here the bone always will be flat. We have to keep the receiver well here only. The receiver stimulator we have to keep there only by making some distances. Already explained, we should not make anything metal on metal. This is the sound processor. The baby will warn afterwards. This is the template. Always this line should be 45 degrees to the orbitometer line. I will draw these lines for your understanding only. They will be fade up after draping. This is the speech processor. This is the receiver stimulator. This is the electrode array. This is the picture you have to remember in your mind. After, if without even this also, there are anatomical landmarks. We can clearly understand where to keep the receiver well. I will show internally also. Sometimes they use it to poke inside to make a blood contact there also, but they will vanish off after draping. That's why I will do the infiltration with the needle. For this I use two types of needles. This is the 26 gauge 1.5 inch needle. This is the 26 gauge half inch needle. Why I am using the half inch needle? Before giving the infiltration only, I will give my skin incision mark. See, why I am using the bare hands? We have to always palpate the tip of the mastoid. Usually by the age of the second year, the mastoid fully formed. It covers the facial canal also. It protects the facial nerve without injuring. Below the 2 years age, we have to take another care. Avoid the injury to the facial nerve. By here, I am keeping my thumb and also making an impression with my nail. Are able to get the picture properly?
Yes, sir. Yes, sir.
Someone should respond.
Sir, we are getting the picture. Can you hear me?
Okay.
Can you hear me?
Pardon?
Can you hear us from hall?
Yes, yes, yes.
Yeah, we are getting
Speak
clear
loudly.
picture,
The speaker
sir.
is outside. Just keep the speaker inside. Are you able to see my nail bite mark?
Yes, sir. It's clear.
From
we are
here onward, just follow the auricular fossa incisura, means this is the line. The posterior line, just as a curvy linear fashion, 0.5 to 1 centimeters away from this groove, just curvy linear up to the helix. Previously used to mark in so many ways, lazy S, C-shaped, already explained by Santosh. Just I am giving a curvy linear, just C-shaped incision. Why? Just I have given with a small impression over the skin with the 1.5 inch 26 gauge needle. It gives a good mark. After this, you can see the blood will come here. It works as a surgical landmark. After that, I will infiltrate the same 26 gauge 1.5 inch needle. Just you will give a small pick in the midpoint, not going up to the periosteum. You shouldn't go up to the periosteum. Why? Because the posterior fascia, I will explain the posterior fascia. It has so many layers, so much vasculature. Just see what I am doing. Just I am making a bleb of the infiltration. From that onwards, where I have marked the incision, just hydrodissection. You can push the drug towards the tip of the mastoid, then slightly go the needle, just like a hydrodissection. It should be in the layers only. You can see how we can achieve the hemostasis after opening. Like this, you have to infiltrate. Then you have to come out slowly, not totally. Just go towards the tip of the mastoid, go downwards, and also make the needle towards upwards, and also the push some drug, and also towards the line of the incision. See how beautifully the drug is going, and also the some drug towards the receiver well, where we are making the receiver well. All the point is showing here now, without removing the needle from the skin subcutaneous area. Only I am making the infiltration. Sorry. Like this, we have to make the bleb. The drug has to go in that layers only. See the impression, how it was happened. After that, we have to spread the drug all the areas. Taking a gauze piece, small gauze piece. I will spread this drug all over the areas. Required areas. This is enough. It can be practiced for the normal mastoid surgeries also. You can infiltrate like this, you can achieve good hemostasis, and also 2 more infiltrations required, anterosuperiorly and postero-inferiorly, and also the canal infiltrations for the mastoid surgeries. From the cochlear implants, we only dealt with the posterior part, not we go inside the canal on the middle ear. That's why infiltrating here, this it will spread like this. After this only, we have to go for the scrubbing. It allows the proper vasoconstriction. Now, I will explain the postoral fascia while they are draping, scrubbing the area. What is the postoral fascia? The postoral fascia is divided into 2, extrinsic postoral fascia and intrinsic postoral fascia. Pattern. Okay, no problem. You are getting the picture clearly now?
Yes,
The
yes, sir.
intrinsic postoral fascia, whenever we elevate from the pinna, it goes along with the concha, is called the intrinsic postoral fascia. The remaining part of the posterior part is the posterior extrinsic postoral fascia. It was described in the plastic surgery textbooks, not given in any of our ENT textbooks. Why? Because I am eliminating is to elevate the musculoperiosteal flaps, you should know the anatomy of this area. Previously, we used bother to elevate like this, like that, but whatever the way we elevate the musculoperiosteal flap, the primary aim is to cover the receiver well and electrodes by at least the 2 layers. For this, we can elevate superior based or posterior based or anterior based flaps. These are all given in your textbooks. But here I will differ some of the steps, some of the drilling issues also closely observe my surgical protocol. The extrinsic postoral fascia contains 5 layers. That is superficial temporal fascia, middle innominate fascia, deep temporal fascia. Going down is a superficial mastoid and deep mastoid fascias. I have infiltrated the drug between these layers only. Sterilium. Scrub. Sterilium scrub. Those layers only will infiltrate, then we will get achieve the proper homeostasis. Where the vascular supply mainly comes from the scrub undalga. Sorry. The superficial temporal artery and also posterior artery, some occipital branches will supply the postoral area in a mirror image fashion of the auricle. They have very good rich anastomosis in between all of those. That's why you can fearlessly elevate the flaps whatever the way you like and easy for you. Now here I will do a 2-layer technique that is called double breasting. It is easily described in a
Sir, we are not able to
here
see.
also we can elevate the 2 layers, means 3 skin and subcutaneously 2 layers to cover the
Sir,
receiver
video signal is lost.
stimulator and also the electrodes array. Please ask some questions. Hello? Sterilium. And also another important, after placing, positioning and also giving markings for the incision, and also the draping is also most important in the cochlear implantation, because usually ideally we have to do with the proper warmers. Under the warmer blanket only we have to do the pediatric surgeries, because it may take sometimes more times to maintain the proper temperatures. The 2 adverse effects for the pediatric is the hypothermia and hypovolemia. These may cause so much problem to the kid. That's why we have to maintain the proper temperature. For that we use the more drapes to cover the baby in such a fashion to have the proper exposure of the surgical site. Here I will show how to drape the baby also. Routinely we use the head towel first. We don't use any kind of special equipment. These are all routinely available in all the places. You can see the surgical equipment also. These are all routinely, whatever the equipment needed for the mastoid surgeries, and also little more required instruments given by the companies. They will the special equipments provided by the implant companies. There are 3 implants. We have FDA approved in India. All are good. Now we are doing the advanced bionics implant. See, clearly you can see the incision marking. After draping, after cleaning also, it won't fade away. Yes, please. You can clearly see it here. We have to pour some of the blood in the extra-aortic canal. Why? Because if you inadvertently damage the posterior canal wall, the blood is coming to the surgical site, then it is called the bedded in sign. We can take care of that. And during surgery also, I don't talk more about the complications. Why? Because I don't want to keep any psychological or blocks in your thoughts or in your process. First, you learn how to do easily the cochlear implantation. Then you will come across about all of the complications and also the anatomical variations. You can see now I am draping the head. Sir, just lip chair, without touching here. Just up. No, not the tongue, only head. Just head. Okay, thank you. Okay, leave it. I am draping the head with the towel, head towel, keeping it 2 layers, 1 layer like this, 1 layer like this, and keeping a towel clip superiorly, and also small glass piece. First, you have to dry up the area to have adhere the special drapes, adhere drapes. Why? Because in cochlear implantation, most of the times 3-4 assistants number also. For easily making this, we have to dry this body towels. We can put in triangular fashion, V-shaped fashion. You can see like this. First you put the towels, then only we apply the drape. It is the easier way to hold the drapes without applying the more towel clips. Like this, this is the one towel. Body towel. Next, the full towel. Na phone chodandamma. Na phone. This is the area required for a rectangular shape of area required for the cochlear implantation. Now we can fold the ear anteriorly, just like this, and also dry this. See the marking, it won't fade away any time. Open cheyiddu. First it like it. Just we have a special drape, peel out the white paper. This is the adhesive surface. Take this tape and apply over here up anteriorly up to this area. You can apply this one. This is the simpler one. It costs around 30 to 40 rupees. Just apply this, then you can open up this totally.
The external camera can show it better. We are not able to see. We are seeing back of somebody.
Okay, Miraka. Now you can see how I applied the drape now. The auricle is folded anteriorly.
Yes, sir. Very nice. Yeah, that's the IOBAN you have applied. Yes.
Required for the surgery.
Yes.
This is enough C-shaped incision done. Then we have to take the seat.
This was very nice, sir, to show from the very beginning, because these are very important parts.
Yes, because in our ENT surgeries, all are the exploration only, normal and structural exploration. In a proper way and proper position only, you will get these structures. Otherwise, you have to explore the round window. This is called a neutral position already I make, and also in adults, the head size is different from the body size. That's why you have to keep the shoulder pillow always, or the rolled towel, to get the proper neutral position. After this, my position also important as a surgeon chair. Chair amma. Towel amma.
Also, please speak about the ergonomics, as you started mentioning your position. That's very important.
That's why because as a ear surgeon, we shouldn't strain our backs also. That's why you have the proper positioning for the surgeon also important. And also this is it has to be done in the most sterile conditions. That's why you use the sterile towel on the chair. and also making the chair as a comfortable level depends upon the position of the microscope. ఇది పైకి వస్తాయి ఇంకా chair. రాదా సరే ఓకే కొంచెం టేబుల్ డౌన్ చేయండి అమ్మా. We have to sit in a proper way. You have to have the back support and if needed the support for your arms also. Table konchi kinda. And also previously you can see the picture of the type machine. Type machine this position. You should have the support for your legs also. You have some table under the leg. అవి కాదు నాకు కావాల్సింది దీనికి హ్యాండ్తో కంట్రోల్ చేస్తాలే. And all instruments you have to make for your left leg has to habituate for the cautery machines and all, right leg for the powered instruments. Why? Because all of you know to drive the car. Like that we should know how to accelerate and decelerate. Why? You have these foot pedals for the right leg and cautery for the left leg. Cautery left. Bipolar. Here also one point you have to learn about. I won't use monopolar cautery in implementation. Always I will use the bipolar if needed. I will minimize the usage of cautery as much as possible. Why? Because the viability of the flaps and also healing also depends upon the cautery usage. We shouldn't inadvertently use the cautery. Are you getting the external picture? Okay?
The picture is good, sir. We are
okay,
able
this
to
is my
see.
position, but the chair is not good. It's going back. It has to support our back and also sit like this. And also one more precaution, one towel. I will always use one drape from my chest to the table to prevent the dropping of the instruments on the floor. It always helps for the instruments in my lap only. Whenever required, I will take it. It prevents the delay for the giving the instruments by the assistants. One more drape. త్వరగా టేబుల్ కొంచెం కిందకి దిగుతుంది. దిస్ ఇస్ లోయెస్ట్. అయితే చైర్ తీసుకోండి, స్టూల్ తీసుకోండి సార్, చూస్తాను. ఐ విల్ టేక్ ఫర్ ద మైక్రోస్కోప్. జస్ట్ షో ద మైక్రోస్కోప్ ఫస్ట్. స్టెరిలైజ్డ్ కవర్, స్టెరిలైజ్డ్ టచ్ చేయి. ఓకే, ఐ విల్ టేక్ విత్ మై హ్యాండ్. ఐఎమ్ సీయింగ్ ద పొజిషన్ ఆఫ్ ది మైక్రోస్కోప్. Fun because each and every microscope differs and also in both ways for the axis and to distances and all. Okay. Always should have the smaller head. Are you getting the clear microscope picture also? Okay. But the working distance also we should know prior to the surgery. Okay. Now I am doing the part with the external camera. Just keep it there. Where is the towel? Srinivas? I am keeping the towel. See how I am placing the towel from my chest to the table. Can fix it with 2 towel clips. These are the little steps. It prevents so much usage. Whenever the very needed instruments falls on the ground, it cannot be sterilized easily. That's why we have to take care of these things. We can keep everything in the lap. Now I am going to make here already I have described the extrinsic and intrinsic postoral fascia. We are doing on the extrinsic postoral fascia. The incision already I have given like this and also starts from the skin only, not going deeper. Just you have to incise the skin along with the curvature up to the tip of the mastoid. You can see. Are you able to get the actual? ikkade unnaru.
We are able to see your skin incision, sir.
You are seeing the incision?
Yes, a little bit zoomed.
Zoom.
Yeah.
See, there is no blood at all.
Because you
Are you
spent
able to
enough
appreciate
time after giving the
how
local
much the
anesthesia.
vasoconstriction happened. After you have to take the 15 number blade and also holding the posterior incision flap, you have to elevate the skin subcutaneous plane only without disturbing the internal muscular flap and the fascia. Just below the subcutaneously you can elevate the flap. Undermining of the skin, that is called. Thank you, Naidu. Just undermining the skin. Here I am accidentally touching the vein. For this I apply the cautery. Where is the more? Bipolar cautery. Oh. Bipolar. Maaf cheyama. Okay. Okay, chalu. Just for wherever needed only I will use this cautery. Usually I don't like to use the cautery. Just make the subcutaneous flap. And here also one movement I will do, just like a dragger, while we are holding the adenoid forceps, just keep a subcutaneously insert this back of the BP handle and we make this space, upward and downward movements to have the space. Just this, why? Because the receiver stimulator is the bigger one, the wider one. This is the parietal protuberance, this is the mastoid protuberance. In between there is a flat area, and also I will show the internal landmarks, how to identify the area. Just like this you can make a pocket. With pockets below periosteum and also the skin. Why? Because the space, the void space can lead to the collection of the blood. It more problems. And also now see the anterior part.
So we lost it. We lost the picture.
Now the external camera, getting external
Yes,
camera?
yes, we started getting that.
Only microscope.
So we are getting the external good, so you can show the flap elevation.
Put the both microscopic and external both I have arranged. Itrama. Now you can see, just I am here like posteriorly also I am making a only subcutaneous elevation to make some more fashion. Here I will take a flap.
Sir, ask the camera person to focus on the field.
I can take a small flap, anterior basal flap from this postoral, extrinsic postoral fascia. You can see this is so much tissue is here. I will take a parallel incision. Why, how useful I will explain later. I am taking with the parallel incision one small thin layer anterior basal flap up to the postoral groove, posterior artery canal wall. See, Gaspis. Without touching up to the periosteum, just small layer I have elevated. You can palpate here the anatomical landmark, anterior boundary is the posterior artery canal wall. Up to there I am taking that this flap. This is the flap, anterior based flap. Okay? Clear up to this point?
Yes, sir.
Sampurna ji, clear this point?
Yes, sir. Yes, sir. Now the camera is also showing right.
You have to convey the message. Now, after going this, I will give the special tips to elevate the superior basal flap. This is the U-shaped flap. It has to come like this. For that, you have to palpate the mastoid tip. Already I have told you now. This is the mastoid tip, Gaspis. From the mastoid tip, see, I didn't using the any type of cautery from then onwards. This is the tip of the mastoid where you have to go deep, just like a blunt incision, applying a horizontal incision over the tip of the mastoid. You can see. See?
Yes, yes, sir.
From the posterior end of the horizontal incision, go posterior superiorly. Posterior superiorly. Here, sometimes we may come across the mastoid emissary vein. Don't worry about all those things. I am not uttering about the complications to prevent the blocks for you while doing the surgery. just go along on the bone. We shouldn't make any multiple incisions. Just go to the bone deep and make a incision. See the incision, there is no bleeding at all. And all the same way, it retract chema. Rondito retract chey. From the anterior part of this horizontal incision, this is the horizontal incision, this is the posterior part limb, this is the anterior limb, go along antero-superiorly to make the wide. Here we can come across the vessel also, no problem. Just combine these two lines. See how I am doing.
So what is the age of the child here?
Child age around 4 years.
Okay. Will it change any of your soft tissue incision or plan if the child is 1 year old or
No,
younger?
nothing. Everything same from the 8 months baby onwards. We did for the 9 months baby, the youngest, more than 8 kgs should be there. Na cartry point ekkada. Oh, okay. Now what I have made you can see in the textbook also like this only. This is the called flap. From here, take the tip just to tease the fibers from the tip. How the flap will go elevate. For this, you can use the Freed's elevator, the lateral end. You have to apply the pressure over the bone, not on the tissue. Just to tease from this one. Lagu. You can see clearly. Just tease the fibers from the mastoid tip. Later onwards, the flap it goes on easily on its. Just peeling the flap like a banana. Just see how it's going easily. Our assistant will help to elevate this. This is the area you have to expose the mastoid cortex.
Superior,
All of you clear for this part? How much time it taken? In my case, I used it to take 2 to 3 minutes. Elevate these all these flaps. These are the again we have come from the landmarks. This is the triangular area of exposure. Superiorly parietal and the mastoid tip, anteriorly the canal wall. Here I will make some more tissue dissection before elevating from the canal wall. Usually I won't elevate the skin from the canal wall just to identify the landmarks. What are the landmarks here? Always you have to follow the landmarks. Nowadays Google has destroyed the memorizing the landmarks. We are following blindly to the Google. Not like that. Here we have to always follow the landmarks to prevent the accidents. Here just I am also exposing the tip properly. Just tease the fibers from the mastoid. This is enough of the exposure. We shouldn't elevate from the skin. This is the fovea mastoidea, spina fili not properly developed, and also the tip of the mastoid. This is the elevation. Now I will use only the mastoid retractor, the self-retaining hemostatic mastoid. Previously in my learning days, we used to put the neuro clips, hearing and everything, so many issues. Just keeping the mastoid retractor by placing a small gauze piece to prevent the pressure over the flaps. Just keeping a small gauze piece like this below the skin up to the inferior part of the incision, and also apply this 3 prongs or 4 prongs mastoid retractor starting from the tip onwards, not from the middle. You can see what I am saying. You can blindly follow these steps. You can get easy exposure not only in the cochlear and also in the mastoid surgeries and colchitomas. Apply. Just as much as possible apply. If required, you can apply second retractor posterior and superior inferiorly to expose the tip of the mastoid. This is about the exposure. Now the drilling part will start, and also position is perfect. We can make like this. Now we are taking the microscope to start the drilling. The tip is important. Why?
Yeah.
Why? Because sometimes all of you forget about your drilling techniques. Just see what I am doing. It is very useful. It was not given any kind of textbooks. I am practicing more than 10 years for cochlear implantation, for all other my ear surgeries also. This is called the reverse drilling technique. Are you getting the clear picture? Ekkada focus. Ive. Maybe. Ide. Idi kaakunda paiki kinda movement.
We need to focus, sir.
Yes, I am trying to do
yeah.
focus.
Just when sir is adjusting this, just a take-home message that when we go for cadaver courses, or usually we focus more on doing the drilling, exposure of the round window, But you see how much time sir has spent just to drape and to do the soft tissue work. And the soft tissue work is utmost important. Even it is more important than the drill work, because that will give the long-term result, a good wound healing that will prevent extrusion
And
of the
also
device and displacement of the device as well.
After positioning in this place and I'm start drilling, is it clear for you? Is it clear?
Yes, sir. Yes.
The picture is clear, or some more adjustment required? Just see my drilling technique, forget all things for some time.
Yeah.
And also, what I am starting from the tip of the mastoid. Usually,
The external camera has to be focused.
Microscopic picture you are not getting?
Microscopic we are getting.
Okay, axial
The
camera
focus
also
is
from this
different. Your focus and what we are getting
This
is
is
little
our-
different.
You. Okay, even though they are arranging in 2 minutes, see my positioning and also placing, taking my hand rest on the shoulder of the baby, and also starting from the tip of the mastoid. Classical sayings are the attack of triangle. This is the fovea mastoidea. The medially we can find out the mastoid antrum, but
It's
any
clear
kind
now, sir. It's nice now.
even the juniors can easily drilling without having tension. Because why? Because here you have to remember the anatomy of the temporal bone. Here this part of the temporal bone is called there is no mastoid part of the temporal bone. For the postgraduates and also the ENT surgeons, this is formed by the 4 bones: squamous, petrous, temporal, and styloid process. These are the 4 bones will make this final picture of the temporal bone, and also anterolateral part formed by the squamous bone, posterior middle part formed by the petrous bone. That's why this anterolateral part of the squamous bone doesn't contains any important structure in it, any important structure. And also we can know it what are the structures present here by seeing the CT scan. Here I am starting from the tip of the mastoid, just to drill the tip of the mastoid in. Just starting from the tip of the mastoid. See, just on the tip only, I am going on the tip, find out one of the cell from the tip. Okay, I am able to find the one cell. This is over. After finding the cell tip of the mastoid, you can blindly follow the curvature of the anterior superiorly with the bony canal, posterior bony canal. You can blindly follow. Nothing worry about any of this. Just blindly follow and reach the spina fenley area. You can reach the mastoid antrum easily. The mastoid antrum is the largest air cell present in the temporal bone. Since from the birth of the baby, the size is same. The lateral margins, lateral relations will vary, but the size of the mastoid antrum won't change since the birth. That is around 10 mm size. Now you can see what I have reached. I have reached all the mastoid antrum and also the posterior epitympanum with a single go. I am stopping for your understanding sake. I am taking out this retractor also. See, now are you able to understand some of the anatomical structures there? Someone should respond.
Yes, sir.
Easily,
Yeah.
where I have started from the tip of the mastoid, blindly follow the canal wall. And also now I am going deepening. What is the medial extent of the mastoid drilling? Mastoid drilling. It roughly takes
What is the
2 to
reason
3
you started
minutes
from
only.
tip, sir?
Pardon?
What is the reason of starting from tip?
Yes, that is the reason is it doesn't contain any important structures here. Previously in the surgical drilling, Santosh has explained coming from superiorly, from downwards. Here you have so many structures. The dura, you don't know the position of the dura, you don't know the position of the sinus, you don't know the thickness of the hair. If you come from the tip of the mastoid, follow the canal wall, see how I am doing, how much time I am taking to drill all these things. See, here I am already reached the antral cell and also the second landmark.
Sir, when we are starting from the tip, in the pediatric age group, the facial nerve will be
even
more
up to more than 1
lateral.
years of age group also, don't worry about the tip. Lateral to the tip, you can find the air cell is the safer one. You can drill along with the canal wall. Already I have reached the posterior epitympanum to have the anatomical landmarks. Meanwhile, I am also making the well in a way. It is differs from the routine mastoids. There we have required the overhanging edges. We shouldn't go for the saucerization. Most of the places I have gone as a mentor, I am seeing all the people, not only the juniors, seniors also, using that Sahasra technique, you shouldn't use that Sahasra here. To hold the electrodes, we have to have the overhanging margins, and also I am differ with the seniors by making the cavity is very smaller, and also tympanum is very smaller. Now you can make a small move, rotate the head away from you, you can get the constant landmark. What we have required is the lateral semicircular canal, and also the medial boundary to drill the mastoid is the lateral semicircular canal. Now I am able to clearly see the lateral semicircular canal. See my size of the cavity. You have the scale.
We don't need the external. Please keep the microscopic only.
See here, this is a bulge
Lateral
of the
semicircular
lateral semicircular canal. This part of the bone also comes under the squamous part of the temporal bone. This is a scutal area. This thick bone we have to remove. Sometimes we have to come across the corner septum, separate the mastoid into two parts. That is the fusion line between the squamous part of the temporal bone and Petrous part of the temporal bone. Here the beauty is we are dealing with only the Petrous part of the temporal bone, or our important structures present in the Petrous part of the temporal bone. With the same burr, the large burr, I am doing drilling from medial to lateral, not lateral to medial. Always if you go inside, you have to follow the steps like this only, from medial to lateral, medial to lateral. Here the fovea mastoid I am drilling at the area of spine of Henley. Here you can have two landmarks here. What is the structure coming from superiorly? Anyone? Anyone? I will give a special gift for them. I will point out after making something, magnification, increase the zoom. Yes, 1 minute. Now you can clearly see this microscope not little.
It's point with a curved needle, sir. What you are showing or asking.
I will show.
Yeah. And the burr size, is it a 4 or 5 like that cutting? What size
cutting
is
burr.
that?
Zoom tagitsu. Okay. Because of the newer microscope, this is a different one. That's why I am taking such. I will expose that area clearly for our understanding. And at the same time, I am making the well deep from the tip to the canal wall. Why? It makes easier to make the posterior tympanotomy easily. Just I am hugging the canal wall, I am making as thin as possible. Previously it used to describe it as a chain of bone, but nowadays also I am not doing like that. If you make very thin also, it causes complications. It has to protect the mastoid cavity anteriorly.
Sir, what is the size of the cutting burr you are using now?
That is 4 mm.
Okay.
Pick ikkade unchandi na ullo unchandi tiyaddu. See what is the importance I will tell. This structure. What is structure? Madam also explained, Varsha also. This is the tegmen mastoidea. The mastoid tegmen bone formed by the fusion of this famous part of the temporal bone and all the medial part of the temporal bone. The joining line, this is the line comes like a one. We have to keep always this projection. Why? Because the folded electrode, it holds properly, it prevents outside extrusion of the electrode. That's why we shouldn't drill. Routinely while doing the mastoids, everyone drilling everything and making everything a smooth cavity bone. We shouldn't do like that only. Why? Because this is physiologically functioning mastoid. This is not the diseased mastoid. That's why we shouldn't follow the here and there to extend the all air cells. Only we should follow the anatomical landmark to reach the important area of the round window. Now I will change the burr to the smaller size. Zoom. Little bit zoom. Otherwise, I am making a magnification some more. Whenever I am going magnification, I have to go far from the field. That is the problem with these higher end microscopes. M3500, 320 is the better microscope for ENT practices. Here I am drilling. Not clear, I think. Okay. I will adjust the file. Now what I am drilling is the scutum area. That is the lateral boundary of zoom tagitsama. This is the lateral part of the posterior epitympanum. No. Okay, sorry. This is the scutum bone where I am dealing with. Here also you have to drill from medial to lateral, medial to lateral. You shouldn't go deeper. If you go in this area deeper, you can disarticulate the ossicular chain, you can cause the damage to the artery mechanism. That's why just if you require, you can turn the head some more to opposite you or towards the opposite ear. You can see this is the, are you able to appreciate what I am doing?
You are trying to
Yes, yes.
open the
Just
epitympanum.
millimeter by millimeter, you have to go like this from medial to lateral to find out the second landmark, that is the body of incus and short process
Short
of
process
the
of
incus. Like this, I am able to see the incudal shadow and also incus directly, superior incudal fold,
Yes, sir.
small section. Is it clear for you?
Yes, yes.
Okay. You can find the spaces. I will explain some of the triangle here. The table height. Tagada inka? Sorry. Okay. The pick. Here I am explaining some more thing for your understanding. What I made is the antrum and also the itis antrum. Itis antrum around 4 into 4 into 4 centimeter size. Here you can see this triangle. And I am named it as a medial incudal triangle. The space of the triangle roughly gives the idea to make the posterior tympanotomy the same size. We have the better space here, and also like here also we can have the better space. All of you worry about the how to avoid the injury to the facial nerve only now. I will show the tricks how to avoid the injury to the facial nerve here. This is the body of incus and tip of the short process of the incus. This is the line. The line demarcates the internal vertical part of the facial nerve up to the digastric ridge. Here we have the so much bone to drill without causing damage. Here from the lateral dome of the semicircular canal, just 2 mm medial to that only we can find the facial nerve. That is the second genu part. Here what I will do, I will make a gutter like drilling with the same size burr, what I have used there, along with the canal wall. Here the textbook sayings are always follow from superiorly inferior wards, but it is better come from caudofacial angle. If you are able to find the cauda, it gives the good anatomical landmarks to drill here. And also one more point here, most of the times around 44% of the patients will have a cell that is called the Herald cell. It leads to the mesotympanum easily. You can follow cell, you can blindly reach into the mesotympanum. Here also I am making millimeter by millimeter drilling based on the lateral semicircular canal and also the short process of the incus. I am going just like a gutter shaped drilling. Most of the Western surgeons, they will find out the facial nerve first. Here also I am able to find the facial sheath laterally. It gives my surgery is easier. Now I will change into a smaller burr. There we have to make triangular. The relations are antero superiorly by the cauda, posterior medially by the facial nerve, superior by the incudal buttress, where the short process of the incus plays over that area. That is called incudal buttress. Here I am able to find the sum of the cells. This is the facial nerve. I am going here, hugging the canal wall closely, just millimeter by millimeter. We have to go deep. In this direction, sometimes you may damage the second genu, but you have to always see the canal wall. Now there are air cells, and slowly by millimeter you have to drill it. Whenever you come across of the blood, you have to take care. That is the perineural vasculature will cause the bleeding. With my right hand I am doing this one in the triangular fashion. The base of the triangle is superiorly, the apex towards the caudofacial angle only. Here I am using the cutting burr. Previously I used to do with the diamond burr. I have prevent using the diamond burr. Diamond burr will produce more heat than the cutting burr. Sometimes the heat will sometimes causing the paraxia of the facial nerve. Now I am reaching the middle ear to the posterior tympanotomy.
Do you always expose the nerves and then go into it, or you just target the Herald cell and...
I never expose the nerves. I never use the facial monitor also. If you have the luxury in the OT, but without having also we are able to do this part.
How was the CT scan of this child, sir? So do you focus on the CT, how
CT,
well pneumatized or how much?
Focus. We will discuss later on outcomes. Otherwise they have in the system, they can show there also. Just I am going medially. Now you can see the fluid movement here.
Yes, yes, sir.
Okay?
Yes, sir.
And
It has
also if
just
you have
opened
any
up.
doubt, Just take a small pick to enter into the mesotympanum. Just this is elevate this one. You can see the hole. This is the space what I have created. Take the small size suction. See, this is the middle ear glue also coming from that. Based on this opening, you can widen the required area. Here you have to follow the two principles, that is called the visual axis or optical axis. The second is the trajectory. These are the two main principles to reach the round window. Because I used to practice with the very narrow cavities, narrow things.
Sir, size of the bar?
Bar size is around 1.2 mm only. 1.2.
But do you recommend beginners also to use cutting bar here? You have done many, so shouldn't we do with diamond, or you think you will when you mentor, do you ask them to use cutting?
You have any doubts regarding the finding the facial nerve? Better to go for the smaller diamond bars to reach this area. Okay. Later on, after getting the acquisition of the anatomical knowledge, you can go for the cutting burr. Now you can reach here. There are so much anatomy described in endoscopically. The endoscopical surgeons, they will describe so many three ridges, three eminences, 5 ridges. Make the space into 4 parts. That is the posterior part of the mesotympanum. Retrotympanum is divided into like that because of the bone. The mastoid bone separates the mastoid cavity from the middle ear cavity. There are so many structures. That is the pyramidal eminence, acts as a fulcrum. Here caudal crest. I am going slowly for your understanding. I have reached the middle ear. You can see the third landmark directly. What are you able to see? Someone? Juniors? Is it clear? Pick. This is the first landmark, second landmark, third landmark. That is the pyramidal process and also the stapedius tendon.
Yeah, the tendon is clearly seen, sir.
Stapedius tendon. Are you able
Yes,
to
we can
clearly?
see.
Yes,
We can
sir,
see
clear.
clearly.
This is the third landmark. After coming to the third landmark, you can safely drill that area of tympanotomy, making the view like this, and also coming the microscope angle. You can change the angle towards caudal area.
That was quite fast, sir. Actually, like super fast.
If you won't stop, I will go.
No,
some
nice.
more.
That is encouraging.
You have to stop me, otherwise I will go very fast. Now, based on this, now you can see the fourth landmark is the promontory. I can see the promontory
Yes.
also.
Yes.
Where you can safely go caudofacial angle, whatever the area required for your.
Welcome, we
have
welcome
to
NCK
make a
Reddy, sir.
workspace here to use the equipment to make that. Also, I am able to see the shadow of the round window niche. I am not about the under. Simply, I am do. Why? Because cholecystoma is more challenging than the cochlear implantation. As an otologist, everyone should learn how to do the cochlear. That is my main motto of demonstrating. I have mentored more than 20 centers, more than 100 ENT surgeons. Like this, able to do the surgery. Now you can just rotate the microscope towards caudally and also make a head like this. You can see the round window, superior lip, round window knee. Here I will make some more drilling of caudofacial angle. Here I am seeing the facial nerve, that's why I am not doing much drilling here. As much as possible, you can thin the facial canal. Why? Because we shouldn't clear another deformity of facial weakness. Already suffering with the sensorineural deafness. The bone hampering the view of the round window niche. I will drill somehow. If required, you can expose the perineurium also, nothing will happen. Up to that we can drill safely.
Sir, now that you have entered the middle ear, there is no risk of damaging the annulus and all, but what are the tips that you advise?
Pardon?
Now that you are in the middle ear,
Yes.
there is no chance that we might damage the external artery canal or annulus.
Yes, yes, you shouldn't damage the external canal. Unless
No, what are the tips that you give?
tips always the cauda. Cauda tympani is medial to the 2 mm medial to the annulus.
Yes, sir.
If you damage the annulus, it causes later on the development of the cholecystoma in cochlear implant patients.
Yes, sir.
That's why we have to preserve. If you do the damage to the cauda also acceptable, but the damaging the annulus, the shape of the annulus, the groove and all are the different teachings. We can discuss if time permits.
Yes, sir.
Now I have reached the medially where I will show the special technique. Here sometimes in these times we need to have a that is called what is called skeeter. We don't have the skeeter drills and all. We are using the simple Shishan micromotor. నాకు స్టూల్ వేస్తారా స్టూల్ వేయండి నాకు ఎందుకు చైర్ ఈజ్ వెరీ లోయర్ ఐఎమ్ అనేబుల్ టు స్ట్రెచ్ మై నెక్
Angle also, sir, right?
pardon
With a contrangle handpiece will also help if
yes
you
yes
don't have the
contrangle
skeeter.
handpieces also will help or the skeeters will help
Yeah, contrangle with a long length bar so that
yes ముందుకు
yeah, the length should be different.
పెట్టారా? పడతాను కింద
And we need to be
కొంచెం
careful
height
that the shaft should not touch while drilling the facial
good.
nerve
Abba.
area.
ప్రశాంతంగా ఉంది లేకపోతే నా మెడంతా పోతుంది ఓకే నౌ ఐఎమ్ కంఫర్టబుల్ ఐ చేంజ్ ఇన్ టు స్టూల్ ద చైర్ ఈస్ వెరీ లోవర్ okay up to this mark any doubt I have reached this one here I am showing how to drill this area to prevent damage to the facial nerve I will take into my left hand like that yesterday Dr. Srinivas Kishore used the wand with the left hand also like this I can use my both hands to drill in such a way to go inside just take the left hand and keep away from the facial nerve medially we have to dissect see how I am doing why because with the left hand won't produce any contact of the burr stem
Okay, sir.
tip of the burr only we have to touch the stem of the burr will causes heat and also produce trauma to the facial nerve like this now able to see the anterior lip
Anterior lip of the wall window is seen, sir.
all
Clear.
you have seen and some more worried of this facial nerve is see are you able to see the facial nerve sheath
Yes, sir. It is coming into the.
it's coming into the way పోయిద్దు seeing the tip of the burr I am making medial drilling if required if you won't get the proper exposure you can drill the pyramid also and also the stapedius muscle safely
Yes, sir.
this is the pyramid I am reducing this height of the pyramid here the facial nerve always lies posterolateral to the pyramid posterolateral to the pyramid this is the facial nerve sheath with my left hand I am doing this is enough for me to introduce the electrode are you able to see the electrode this is not the type 1 round window during lecture Santosh explained this maybe comes under type 2 or 3
It's quite
for this I will
posteriorly
use some
turned.
more another technique to have the proper visual axis I will push the canal wall anteriorly with
Sir,
the fields elevator
Can we thin down the canal wall more? If
without damage pardon
can we thin down the canal wall more?
it's already thinned out just for that I will say just I won't without breaking the canal wall just I will push anteriorly see the movement what I am making is I am pushing anteriorly to have the visual axis proper okay are you able to see this round window now
Yes, sir.
clearly we can make it break and take it out and also keep it there those are the different I don't want to complicate the surgery for your understanding ఇది అసలు ఘోరంగా ఉంది see this is my visual axis we are seeing through the posterior tympanotomy the narrow area pick. Here you are able to see the round window, true round window membrane. The color of the true round window membrane is the grayish in color.
Yes,
It
sir.
was covered by the false membrane, that is the whitish in color. In autosclerosis and also the labyrinthis ossificans, you can get this type of whitish appearance. Here I am making the mucosal incision all around the round window niche. This is the posterior superior bony overhang. This is the anterior bony projection. I will expose
Is
the
it the
membrane
maximum
afterward.
magnification, sir?
Pardon?
Will you increase the magnification for the
Zoom.
audience to see?
Already
Yeah.
it is.
Is it maximum?
Can you zoom it to focus on the round window? Here?
Yes, I will zoom it. Just I am giving a mucosal incision. Why? Because if you don't do this while doing the work on the facial membrane and all the insertion, you will get the bleeding. That's why I am elevating the mucosa all around the facial niche. From here onwards, then I will expose the round window later. I will keep the adrenaline gel foam here. Up to this, the 90% of the work will be over. Identification of the round window. But sorry, I forgot to enumerate the surgical steps already given by Santosh also. The skin incision, musculoperiosteal layers, mastoid exploration, and also posterior tympanotomy, round window delineation, receiver well preparation. Now I am going for the receiver well preparation, fixation of the receiver stimulator, and also cochleostomy or the electrode insertion, neural response telemetry, fixation of the electrode and closure. Now here, and also I will explain external camera.
Yes, sir. We need the external camera.
External camera. Here beautifully I can explain the landmarks. What I have explained outside the skin, here also. Why? Because God already given everything clearly. We should follow the anatomical landmarks only. Where to keep the receiver well, that is the most important aspects, because previously they used it to explain it has to keep away from the 2.5 centimeters of the posterior margin of the mastoid.
Sir, we
How
need the
to-
external camera to be behind you, sir. It is
How to measure that 2.5 centimeters? Some of the fellows will do the large, wider mastoid cavities. Some fellows like me do the smaller mastoid cavities. Is not the correct landmark to measure from the posterior margin of the mastoid cavity.
yes, sir.
Are you getting the external canal?
We
External
are getting
camera?
the microscope picture, but we request the external camera to be focused
Okay,
on
okay,
that
okay.
area, sir.
Okay. Now are you seeing that one?
This is better, sir. This is much better than microscopic picture.
Okay, now you can see the size of the mastoid. You can see what I have made the size around 2 centimeters superior inferiorly,
Yes, sir.
hardly more less than a centimeter of posterior anteroposterior dimensions. From here they used to say 2.5 centimeters. Where to go? If the mastoid cavity comes like this, where to go? Forget about all those things. Just see these landmarks. I will show the landmarks. Here how to elevate the musculoperiosteal flap. Just keep the slide this Fried's elevator just to lift the flap like this. Okay?
Yes, sir. Yes, sir. Okay.
And also posteriorly like this without fearing of the elevating the mastoid emissary vein. Here you can see the suture lines. Are you able to see? Pencil.
Clear, sir. Suture line is
Clearly.
clear.
Retractor. అటువైపు retractor పెట్టమ్మా. నువ్వు అటు పెట్టుకో. పైకి పెట్టుకో. See, this part of the bone is the squamous part of the temporal bone. This is the squamous part. You can see this is the parietal part of the temporal bone comes like a lip-like structure. This is the suture line.
Yes,
Are
sir,
you able to
suture.
understand?
Yes, sir.
This is the flat area. This is the parietal protuberance. This is the mastoid protuberance. Here the bone always flat.
Yes, sir.
Always flat.
Okay, sir.
This always you have to keep above the suture line. That is the safe area to prevent the one and on the processor and the receiver stimulator. It's away from the post-oral groove. That's why you have to keep here. I am measuring this receiver stimulator well by the templates provided by the company. This is advanced bionics. The model of the electrode. Which electrode? Oh, AB. This is silicon template. For this we have to push. I didn't elevate it much on the subperiosteal area. Just I am keeping like this and pushing. Just push. It's not going because I didn't elevate it. Like this you have to keep the 45-degree angle. I have remembered the orbitometer line. I kept it as 45-degree angle. Are you able to understand?
Yes, sir. Clear.
Near here, likewise the incision I have made with skin with the needle. Like here also I use always the pencil. You can sterilize normal HB pencil. You can keep in the bin. It gives the good marker over the bone. not the pens, surgical pens and all. The pencil gives the good marking for us. These are the markings I will made. Can see the clear markings. Are you able to identify?
Yes, sir. We are able to
Yes.
clearly see it.
Now,
The pencil
here the right
markings.
side we have the special retractor called the Kirtanes retractor. The help of the Kirtanes retractor, we can make easy the receiver well. And also in the previous morning lecture, Santosh shows that how to fix the implant by putting the bony canals and also the screws and all. Usually in the initial days I used to do all those things. After that, after completion of the century, I didn't do any kind of these fixations. I'm reaching 1,000 implants. If you made the snugly fitting well, the implant won't move at all. That was learned by me by doing explantations. One of the case, the failure of the hardware failure of the implant, I used to revise that surgery. Then I learned that the body will form the total thick silicon sheet like thing, that is the connective tissue will drape all over the implant. It fixes the mobilization of implant if you do in a proper way.
Absolutely, sir. I agree.
That's why
In fact,
I don't use
we should
any kind of
reduce.
fixations.
We should reduce all the foreign bodies as far as possible. Extra screw, extra
See,
suture.
go for the as minimal as, and also better to practice the receiver valve preparation also under the microscope. Under the microscope. Even though it is little bit cumbersome, but with the help of the microscope, we shouldn't damage any of the important structures over there. It is clear for you?
No, we need the microscopic picture, so we'll ask them to switch.
In
Just a
fact,
moment.
with the thinner implants
also-
coming, the drilling is also probably in some thinner implants it is avoided. Just a very good tight periosteal pocket
Just
can
here see
also hold it.
What I have applied the
Yes, sir. We have got the
retractor.
microscopic picture.
Over that, to prevent the skin coming in between, we have applied the 4 prongs mastoid retractor what we have used initially. Are you getting the microscope picture?
Yes, sir. It is clear now.
Because why? Because my surgical part takes lesser time. The exposure is taking more. Now I will start count the time from now onwards, how much time I will take to make the bed. Always I used to take the 1.1 mm cutting burr to make the boundaries. If you go to the fields to make a water flow, we used to learn how to make the canals. Like this is the template already I have made. I know the size of template in my brain also. Just stay inside the line, not the outside. Why? Because if you make the smaller cavity bigger easier, we cannot make the bigger one into smaller one.
Yes,
Like
sir.
this, you can make a smaller cavity first, the smaller receiver well first. Then onwards, you can adjust the size later on. That's why I'm giving just parallel to the bone, with the cutting burr. We shouldn't apply the force over the bone. Just the burr has to drill on the surface, and also you shouldn't wobble, you shouldn't jump here and there.
Yes,
If you
sir.
apply the more pressure, and also one side of the burr has to press the bone. Otherwise, it causes jumping.
Okay,
Just
sir.
like a canal, just like a canal comes like this curvature, just like this, and also the anterior part, inferior part, and also I'm going for the posterior
Posterior
one. The
part.
microscope is not cooperating with me. Okay, the posterior one, posterior limb, what I am making, this is the some wider implant around the size of the implant. Am I an AB audiologist? Size of the implant, thickness of the implant. Iris ultra with slim J. The size,
Sir, do you,
dimensions of the implant.
sir, did you ever have to thin out the flap for adult implant candidates?
Pardon?
Do you do adult implants and do you measure the skin flaps? Did you ever
Thinner?
have to thin out
No,
the?
no, I didn't have that problem. Just like this, and also I have the superior boundary. For the beginners, always measure with the template provided by companies. Template, metal template. Previously, we have used the silicon template to draw the markings. Now, you can see the metal template to measure the receiver well size. You can keep always, you have to measure. Why? Because of the experience, I know the size of the implant. Like this, you have to measure, then only you have to make the well.
Bony well.
Making a 90-degree angled walls. Not the, here also, we shouldn't do the saucerization.
Yes, sir.
We shouldn't do the saucerization. Always keep the at least 2 edges with a 90-degree angle. Now I have demarcated everything. I will use the special burr to make the drill to complete within 5 minutes. In my place, I will complete the total surgery around below 1 hour. My shortest time is the 40 minutes. Why? Because he has some new other cardiological problem in Anantapur. We did it within 40 minutes. Kim Savera,
Yes, sir.
Dr. Raghavendra Reddy. Now we can take this special burr. This is the dentist use it to use the polishing burr. It has multifaceted burr. This small burr easily
Okay, sir.
removes the bone like a butter without having any fear complex. Already we made the depth of the well by making the incision over the tabula externa, interna, media and also up to the interna. The outer table and the middle marrow containing table and the inner white table.
Yes,
Up
sir.
to this area we have to make it. Sometimes the thickness of the bone is very thin. We have to make a bony island of the tabula interna to dividing all surroundings to press the implant inside. Here the bone is luckily thicker. This is the marrow containing area. Anterior you can see this dura.
Yes, sir,
Part.
dural
You shouldn't
part.
injure the dura. You shouldn't apply the pressure. That's why nothing to worry about if you expose the dura also, but you should not breach the dural layers.
Sir, any significance of the 90-degree angle that you told to maintain on
To
any of the
prevent
two
to
ends?
prevent the mobility of the implant, the edges has
Slippage
to
of the
hug the walls.
To have the snugly
they
fit-
come out from
Yeah.
that receiver well. And also under surface of the receiver well always smooth, should be smooth. There should not be any bony projections.
Yes, sir.
Have you observed till this part I didn't use it the cautery also.
Yes, sir. Clean.
Cautery, sometimes I feel very bad. Some surgeons use the cautery here and there. They will burnt out everything. If you do the infiltration, what I showed to you,
Yes,
you
sir.
won't get any bleeding in routine mastoid surgeries also. Now I am taking the diamond burr to make the edges proper way. If you find the bleeding on the bone also, apply the diamond burr.
And
It will
stop.
shorten.
Yes, sir.
Now we are making the 90-degree wall. It should not be punched out lesion like bony tuberculous lesions. It has to be
Need
90
punched out
degree.
90 degrees.
I will show from this how to make the wall. Are you clear for this? Okay. I am making 90 degree. Little bit time you have to spend to create the proper size well. It prevents so many problems later on. Okay?
Yes, sir.
Now we'll keep the template. See the size of the well is exactly fitting. There is no space in around. Are you able to appreciate?
It's snugly fitting.
Snugly fitting. This is enough. And also we have to make the electrode array out. For that also I'm use the diamond burr. See the fastness of water. Like we have to come along. I know the measurements, that's why I'm doing easily. Pressure, you shouldn't apply the pressure, only the force, only rotatory force. Silicon template. And electrode array exit also you have to make the same depth, otherwise it causes damage to the electrode array. Now this is the image. You can find out, you didn't find out these kind of images in the textbook also. Take out. We'll take out the retractor also.
Okay,
We
sir.
keep this silicon template to accommodate there and see the size of the
Perfectly fitting.
preparation. Okay.
Correct, sir.
Then here onwards we have to make the electrode array channel. Here some of the surgeons they won't do it, just they will mark the electrode array out. But I will do everything to prevent the damage of the most important part of the electrode. To make a gutter here also, and also always make bridge while entering into the mastoid cavity. Retraction anteriorly. Retract here. Are you able to see this mastoid cavity?
Yes, sir.
There is no bleeding
Shell
at all,
form is
just
removed.
like a dry bone. From here onwards, I have changed the burr bit into the 1 mm or 1.2 mm. To take the electrode array, simply come downwards as a line. Just apply the pressure, come smoothly downwards.
Continue in the same angle.
Do smoothly downwards like this.
Yes, sir.
The depth of this burr head is enough to guard the electrode inside the canal, inside the gutter. After reaching the mastoid ridge, mastoid cavity edge, we have to change to the burr bit and also do one maneuver. I will show how to make the bridge also.
With opposite.
This is the aerate method. Here onwards, what we have make the canal in a proper size without any projections or bony spicules. Here in the right side I use my left hand again. Left hand to enter into the mastoid cavity to make the bridge easily. In the left side I use my right hand. See,
Yes,
here
sir.
also with my left hand to and fro movements I will make this bridge. Always in all cases I will do it.
Yes,
But
sir.
in
Yes,
contour
sir.
advanced electrodes, we will make this one. I will make this hook-like thing. I will make the opening like this. It will also protect like that. This is my
Yes.
practice. Why? Because this bridge helps in so many ways. I will explain while introducing the electrode. This part of the surgery, 95% of the surgery over.
Yeah.
We are able to cover the flap properly. See, this entire flap covering the electrode. We have 2 flaps other than skin. The total covers of the 3 flaps.
Yes,
We
sir.
are doing double breasting. Here we have to check for that. Check for the entire coverage. We have to make some soft tissue work here. Forceps, knife. And also we have to harvest the soft tissue. Knife. Why? Because we have to see it's properly covering or not. Sometimes if there is a gap, we shouldn't have any. Even though we shouldn't have any tightness or the pressure over these flaps. Just I am making some undermining procedure under the skin. Na phone చూడండి అమ్మా ఎవరో నా phone చూడండి. Just I need a scalpel to undermine this one to cover properly without any tension. It should be covered without any tension. Already there is an implant. ఎవరమ్మా? నేను మళ్ళీ చేస్తాను సర్జరీలో. Elevate. Are you able to see the microscope picture?
Yes, sir.
Just to undermine. You shouldn't damage the skin. We shouldn't make any buttonholes there. Just to undermine the skin to have the proper coverage by the musculoperiosteal flap. Okay. Now also
Yes.
I am not getting any kind of bleeding because of the infiltration effect. You can see easily. We can close it. Okay. Without tension. Like this anteriorly also. The first flap. To covers the entire area. Then I will take this. This is the lymph node muscle. Take the tissue for the sealing from here. Usually the periosteum is the better sealer. If you don't find the periosteum, you can take the some part of muscle also. You can keep it. It's also inverse. Okay. Up to this are all clear?
Yes, sir.
It's covering soft tissue work, and also then we come to the final step, how to identify the round window membrane, how to make the entry of the electrode to the round window membrane. Now you can see the beauty. What we have make the flaps, there is no retractor required to hold now onwards. All of you observed or not? I am
Yes,
not
sir.
using
Yes,
any
yes, very
specialized
clear.
equipment here, only the simple 2 retractors, suction apparatus, and also the normal ordinary motor. Small suction. Small. Now we have to go to the fine suctions, and I have a very bad habit of doing very small cavities. Here also the posterior tympanotomy is very smaller one. See, okay? కొంచెం యాంటీ రిట్రాక్ట్ చేసుకోమా. Now the required space, we are seeing the posterolateral wall of the scala, wider scala, that is a scala tympani.
Sir, can you
We have
zoom
to
it on
place the
the
electrode in the scala tympani only. Why? Because like a tree, the stem, from the stem the branches go upwards, the nerves lies in the inferior part. And the scala tympani is the easy and wide scala to access the cochlea. Because of this facial nerve, I am unable to expose the round window for your visualization. I will make somehow like this, the zoom. Okay. Okay. This is the visual axis, it is called, or optical axis. Are you able to see the round window in this area?
Yes, sir.
Not clear.
Not.
Zoom means I have to go back again. Okay, pick, curved pick. Now I will drill here to get the real view of the round window. Okay.
Yes, sir.
Here the textbooks will describe always about the antero-inferiorly. Here the posterior superior bone also will prevent the visualization of the round window membrane. The shape of the round window membrane is entirely, the description of the round window membrane is very difficult. That is the parabolic hyperboloid, just like a potato chip. The irregular potato chip appearance, but we are should not be at round. The anteroposterior diameter is more than the superior-inferior diameters of the round window. Now I am using the 0.8 diamond burr to make this drilling of the posterior-superior bony overhang. Speed the gitsal much pain. We have to reduce the speed of the drill as low as possible. The 800 is always best. 800 is always best. If there, otherwise 1000 RPMs only. The burr motors will comes with the 1000 to 40,000 RPM. Here it is better to reduce the RPM up to the 1000 level. See the speed of the burr. If the speed is more, it causes damage, and also we are unable to find out the anatomical
Sir, can you
structures
focus and zoom in the area of drilling where you are drilling to expose the round window?
1 minute.
Yes. Yes.
That's fine.
I'm not getting the clear. Is it now clear?
Yes, sir. Yes.
Okay. With
Yes.
the higher magnification, I am making the
Yes.
drilling with my left hand. Why? Because I am not using the angled contra angle handpiece and also the skeeter. Just posterior superiorly, we have to make the drilling posterior superiorly at the same way, and also anti inferiorly to expose the 360 degree of round window membrane.
Sir,
These
is
are
not
thin,
drilling the
slim
bony
Jera
overhang
electrode.
to.
Insertion of the electrode is very easier. If you find the path, just I am delineating some more and some more. By millimeter I am drilling this niche. This posterior superior to the antero-inferior called the trajectory. In this way only we can enter the most wider part of the scala, that is the scala tympani. And this, the anatomy of this area is much described, that is called the hook area, to prevent the damage to the basilar membrane, and already explained by the Santosh. And also the cochlear aqueduct and other cochlear vein. See here, still the false membrane is there. We are unable to find out the grayish color, but that is the membrane only. Just give the small gel foam piece to remove this membrane over the true round window membrane. Now I am able to clear somehow. You are getting the gray color appearance now.
Can we use a right angle pick to remove that?
1 minute. Now I am cleaning with the dry gel foam to clean all over the fascia.
Now we are visualizing the grayish colors.
Now you can see the
Yes,
grayish color, and also this is semilunaris, the inferior
Yes.
margin. Okay.
Yes, yes, sir.
Some
Yes,
more I
yes.
will remove this posterior superior bony overhang. Otherwise,
Yes, yes.
it prevents the trajectory. Why?
Yes.
See my suction tip.
Yeah.
That is the trajectory. It
Yes.
has to go in like this only. It always prevent this posterior superior part, prevent the easy access of the electrode. For that, I will make some more drilling with my left hand only. See the proper positioning and also supporting on the temporal bone without drilling here and there. Where you need to drill, there only you have to apply the tip of the burr. One side of the burr, not the all the sides. Here you can see some more exposure. Okay. Okay. Someone should respond.
Yes,
sir,
yes,
sir.
yes.
Means you are unable. If you won't respond, I think you are not seeing anything here.
No, no, we are.
I'm thinking like that.
It's very clear,
It
sir.
is the clear and also very thin membrane, and we can see the perilymph inside. It completes the 99% of the surgery.
Can
you focus a little?
focus and zoom in, sir? Zoom in and focus.
Okay, just a minute.
Now
Ah, yes. Now it's
Zooming and also the
Fo-
elevator.
focus. Sir.
Focus is gas elevator, freeze elevator. You can see now I'm
Oh, yes.
pushing anteriorly to show that one easily.
Yes.
Is it clear?
Yes,
Just a
sir.
minute, just a minute. I will wash. Pick a pick. I will explain the anatomy here. Always in this vision, you have to see the carda. This is the stapedius tendon pyramid, and
Yes,
also the
yes.
inferior part. This is the round window membrane. Clearly, you can
Yes.
see it. Adeline. Now you can clearly see it.
yes, yes.
Okay, just like it can be described as a ice apple. In this season summer we will get the మా తెలుగులో ముంజలు అంటాం, ఇక్కడ ఏమంటారో తెలియదు, ఐస్ యాపిల్ ఇంగ్లీష్. ఇఫ్ యూ కట్ ద ఐస్ యాపిల్ సమ్వేర్ ఇట్ లుక్స్ లైక్ ద సిమిలర్ వే. ఆఫ్టర్ దట్ వీ హ్యావ్ టు చేంజ్ ద గ్లౌస్ అండ్ టేక్ ద ఇంప్లాంట్ అవుట్ అండ్ ఆల్సో వాష్ ద ఏరియా. వీ హ్యావ్ టు వాష్ ద ఎంటైర్ ఏరియా వితౌట్ హ్యావింగ్ ఎనీ బ్లడ్ ఆర్ బోన్ డస్ట్. నా ఫోన్ చూడండి అమ్మా, చూడు ఎత్తి ఆన్సర్ చేయండి, సజీలో ఉందని చెప్పండి. మా అసిస్టెంట్స్ వాడు అక్కడ ఏంటో విషయం కనుక్కోండి. జస్ట్ లైక్ దిస్ వీ హ్యావ్ టు వాష్ ద ఏరియా అండ్ ఆల్సో ద ఎనీ బ్లడ్ ఇన్ దిస్ ఏరియా. ఆఫ్టర్ దిస్ ఇఫ్ యూ హ్యావ్ ఎనీ బ్లీడింగ్ పాయింట్స్ యూ హ్యావ్ టు cauterize now only. ఆఫ్టర్ ఓపెనింగ్ ద ఇంప్లాంట్ ఏంట్రా ఓకే అది I know tonsillectomy bleeding with the coagulation. ఓకే వాళ్ళని రమ్మనరా, దినేష్ సార్ని రమ్మను, దినేష్ సార్ని బయలుదేరి రమ్మను, వాళ్ళని అటు నుంచి రమ్మను. ఓకే, కందుమూరి హాస్పిటల్ తీసుకెళ్ళు. Sorry for that. We have to wash this one and also we have to control the any bleeding points before opening the implant. Why? Because after opening the implant we cannot use the cautery and also switch off the cautery. We
Sir,
have to
which
make
type of
sure
electrode we are
we have
using?
to power. We have to switch off the cautery and if possible remove the cables from the cautery also.
Sir,
And
which is
also all the including the surgeon and all the assistants who those are assisting, you have to change the gloves always. Why?
Sir,
Because this is a very big foreign body we are keeping inside the ear and also near to the brain. If any aseptic precautions make influence to making the infection, if once the infection spreads there, it's very difficult to control. Sometimes may have to extrude the implant also. We take out the implant also. That's why we have to take care of the measures in the operation theater also. We shouldn't allow the more people go inside and outside. We shouldn't touch the any surfaces here. And also now I am taking out the implant. External camera. External camera. Later. Why? Because the taking the implant also very much important here. We shouldn't take the implant away from that. Right. See,
Sir, can you hear us?
are you getting the external camera picture?
Yes, sir. Yes.
While opening the outer foil of the implant,
Sir,
it has to be done on the table, not outside the table. Akkada chupinchu. Open cheyi. After opening the outer foil, there is a inside one more case. You have to have with the artery forceps, lock the artery forceps, lock it and take it out on the table. If accidentally also fell down, it's on the table only. And also again, we have to remove the another foil from the case, and also you have to turn it like this, and you have to open the external one. Before touching the implant, we have to use the saline to discharge the static electricity on the implant.
okay.
That's why we have to submerge the implant in the saline. And some of the implants will contain the ground electrode, then there is no need to do all these things, but these are the single. And also the ground electrode on the base of the electrode only. That's why you have to discharge the static electricity, and also transferring the implant also very much useful. Most of the other implants will have the longer sheath. We have to keep the fingers index and the middle finger, the receiver stimulator well, and the electrode between the little and the ring finger. We have to transfer like this, take onto the area of surgery, and also we have to document the number, serial number of the implant.
Okay, sir.
Serial of the implant. These are for the record purposes. In the government programs, without showing this number, they won't release the fund. Here also, in the private sector also, for the better record sake, we have to take the snap and also serial number. CA 160005 201 5010, the serial number of this implant. This most of the implants will have the upper surface, the serial number. In this AB, these are the under surface. We have to turn this implant and also push the implant below the.
Sir, microscopic picture. Can you
musculoperiosteal. See the microscope picture. You are getting or not?
External camera we are getting. Yes.
Okay.
Yeah.
Okay, just I am sliding the implant under the musculoperiosteal layer onto the well where we have made. It just goes and sits like this without having any pressure. Okay.
Yes.
Are you able to see
Snugly.
this one?
Yes, sir. Very snugly.
Okay. Now, always I make the bridge now. Some zoom, retraction, suction, retraction. And also most of the times I don't use any kind of forceps to introduce the electrode. Most of the times I use it to push with my bare hand. But here the AB, the slim electrode, they have a small silicon projection to hold the electrode without damaging the inner electrodes. See, are you able to see this one?
Sir, microscope.
Yes,
Yes, microscope.
Microscope?
Yeah.
Yes, we
yes.
got
So
it.
now we are getting it.
See, are you able to see? What to see? We have to see the eye of the bird like Arjuna. We shouldn't see all here and there. Just see the round window membrane.
Sir, can you
Here
zoom
the
it? Zoom.
elevation of the opening of the round window membrane also described in so many ways. Sometimes you have to use the small needle to make the crisscross incisions, and also Santosh shown with the curved pick.
Yes. Now it is clear.
But I won't do anything. I will detach the membrane from this attachment, medial, inferior-medial attachment. I will only detach the membrane. Fine pick. ఇది జూమ్ చేస్తే నేను వెనక్కి వెళ్ళాల్సి వస్తుంది. ఓకే క్లియర్?
Sir,
Clear?
zoom and fine focus.
ఓకే క్లియర్, ఇట్స్ క్లియర్.
Zoom and fine focus.
జూమ్ చేస్తే ఇది క్లియరిటీ పోతుందమ్మా.
Li-
ఓకే.
Now it
yeah,
is
okay.
better.
Most
sir.
of the times it has to be done under low straight pick.
Yes.
Lower magnification only, because we will have the trajectory. Now we can see the clear cut view of the
Yes, sir.
నెమలి పింఛంలో కనపడుతుంది మధ్యలో.
Yeah.
Yes.
And are the ice apple. Now I am detaching from the ఏంటిది పిక్ ఇవ్వండియా, ఇది లాగదా. ఫైన్ పిక్ స్ట్రైట్ ఫైన్ పిక్ స్ట్రైట్ టు ఫైన్ పిక్ డెకడ్రాన్ We have to make everything ready before opening the round window. Electrode, receiver well, everything. We can make a crisscross incisions also. Just I am detaching from the crisscross semilunaris or the inferior anterior portion. I am making a smoother one. We shouldn't suck that one. Decadron. Decadron. Under decad లోపల
Sir, focus.
under decadron bath ఏయి లోపల వేయమ్మా లోపలికి వేయాలి ఇక్కడ లోపల వేయమ్మా శ్రీనివాస్ లోపలికి వెళ్ళాలి. It should be done under decadron bath only, otherwise see the air bubbles are coming, the air will suck inside the cochlea. We didn't get the proper electrophysiological testings before opening. Always it has to done under decadron. We have to flush out that air bubbles from the scala tympani. Okay, see, all of you okay for this point?
Yes, sir.
Then we have to push the electrode, because the smaller electrode, it has the sheath. First I will take out from the bridge for your understanding only, otherwise I can do directly. I will take out from the bridge. I will show to the lower magnification.
Sir, focus, sir. There is no focus of the round window. Round window focus
Okay,
is
now we can see the
No,
implant clearly. I can see here now.
implant is visible, sir.
Just I am showing the implant only.
Okay, sir.
How to introduce through the bridge only I am showing this. You can push it like this from the bridge going to the middle ear. Why? Because where to hold the implant I will show. The forceps, jewel forceps. Whenever possible you have to hold this part only. We have to take out this electrode through this area, through this bridge, for your understanding only.
Yes.
And also the AB people will supply the special forceps to hold this area. See, are you able to see clearly?
Yes, sir.
What the specialty of this forceps is, if you apply the pressure it widens tip part. Okay, it won't crush the electrode. See, this is the contact areas are the closer each and other. Now you apply the pressure, it dilates in the tip part. Okay,
Okay, sir.
that is the specialty of the forceps. And also hold this silicon wing, and also I am pushing with my left hand, not the right hand. The trajectory, you can see the my hand suction. All of you observe clearly.
Yes.
How smooth, how I am doing. I am with my left hand. I can do with the both hands with the equal competence. Just I am introducing the electrode into
Sir,
the
can-
scala tympani.
Can you zoom it and because
I will zoom it. First this part has to be done under lower magnification, then I will zoom it to the round window.
yes.
Okay, now you
Oh.
can see. Oh, it
Yes.
came out.
No, it came out.
Sorry. ఇది కాదు సక్షన్ అమ్మా లేకపోతే I can again I will enter easily, no problem. You see the difference. If you go for the higher zooming you can't see the tip, but because of the experience I able to are you able to see that one?
Yes, yes.
Yes, suction without sucking the perilymph away from the tympani. We have to go millimeter by millimeter. Are you able to see the electrodes?
Yes, sir.
Ridges
Very
like
clear.
thing? Huh?
Yes.
We have to introduce millimeter by millimeter, slowly, slowly, slowly. You can count here. It has to be introduced around more than 2 minutes. The good insertion means more than 2 minutes. Count 1, 2, 3, 4, 5, 6, 3, 7, 8 like that up to the 120. Why? Because the scala tympani, it is a closed cavity, circular tube. It contains the perilymph. If you push in a single go, it causes the enormous pressure in the scala tympani. That is equal to the tsunami. That is called a tsunami. The Egyptian cochlear implant surgeon used to describe that is the equivalent to the tsunami. We shouldn't create the tsunami inside the cochlea. That's why millimeter by millimeter. But and also we shouldn't move like here and there. We shouldn't damage the intracochlear structures. Why? Because we have to preserve the residual hearing by millimeter. I am not encountering any kind of resistance. It's going easily. Are you able to understand?
Yes, it's
Huh?
going. Yes,
It's
sir.
going very smoothly, very easily, very smoothly. Millimeter by millimeter I am pushing it. The size of the posterior tympanotomy, see, the size of the electrode, size of the forceps, size of the posterior tympanotomy are the very, very smaller ones. Sometimes I will face the difficulty open this forceps also, the claw.
Mm.
These are the my self mistakes. Making the small cavities, not this one. Okay, I will keep the help of the claw. I am able to remove the forceps.
Yes.
See the beauty.
Yes.
The bridge prevents recoiling out of the electrode from the scalar temperature. That's why I am making this bridge. Bridge is always helpful to us. If you remove your both hands and forceps also, the electrode won't come away. And also this flange, always you have to keep posterior inferiorly to have the electrode contact with the basilar membrane. See this one, we have to keep like this only. Up to the marker we have to push. That is the blue mark, it's gone inside.
Yeah.
Okay?
Yes.
This is the snugly fitting, properly
Yes.
fitted electrode
Yes.
without
yes,
any
perfectly.
resistance, is gone inside on its
Perfectly.
own. See the beauty of the doing cochlear implant. And also here I am using a special technique that is called the double jewel technique to place extra electrodes in the posterior epitympanum only. I have asked a question there, what is that projection called? That is the projection from the tegmen mastoidea. I will keep these electrode medial to the body of the incus. It won't mobilize. If you have the doubt, why don't you keep in the tip of the mastoid? See here, this bony projection won't allow the electrode come outside easily. And also I will keep here a small Surgi cell to lock it here. And the extra electrode will stay always here medial to the body of incus. Give it to me. See the position of the electrode, Surgi cell. Then we have to go, Surgi cell pedadi. I will fix it here. We will go for the neural response telemetry. Names are given by the different companies, how the electrodes are functioning. We have to keep the external issue. External camera.
Any soft tissue seal, sir?
After testing the, usually I will do it, but testing the canal only, we have to fix the electrode. That is the last before step, fixation of the electrode and suturing, repositioning of the flaps and skin suture. These are the last two steps. The separate step is fixation of the electrode. How to fix I will show. After testing only we have to do it. Where is the coil? Till this point, have you have any doubts? Just ask me. We have to recheck the position and also the point where is there inside or not. Wireless. Oh, very good.
Will you please show how he is checking?
Pardon?
How he is checking? Will you please show how he is checking?
With Excel camera we will show that. We are taking in a stimulator. These are come with the wireless the technology. Pardon? No link wireless. It's always better because they can stay outside the OT also, they can do the testings and all to prevent the more number of people inside the OT. And all the companies coming with the wireless technology, I think these are the first or second people. This is the,
Sir, external camera, please.
you can see the with the external camera, we have kept for the sterility process, kept in the glove. This is the coil. I am placing over this area, receiver stimulator area. It was fixed there. Okay?
Okay,
Inside
sir.
the- okay? You can show there.
Computer.
Got a microscope on the connection is not established. Okay, okay, see. Now connected, they are measuring the impedance, stapedial tendon reflex and also the neural response test. These three tests they will do usually. We are keeping in a place. Are you able to see that one electrode is there?
No, external camera.
Connection, sorry, it was came
Yes.
out
Yes, sir.
Yes.
while moving here and there. Okay,
Yes.
you can keep it here, Amma. Okay. I want to show the things.
Axial
Means decadron. That's why we didn't put the, already I told now, sometimes the air may enter into the vestibuli, scala tympani, it causes some wrong readings there, decadron or saline. It will improve, definitely it will improve.
no,
It
no.
inside the,
Impedance is on
scala-
a higher side, sir, because of the air.
I will infiltrate or decadron or the saline we can push around the electrode. You can do the other testings. Can you do with one stapedius reflex? You can see the, all of you observe the stapedius tendon. Sometimes we can get the stapedius reflex while,
Sir, zoom in the microscope. Yes.
okay, I'm zooming.
Zoom in as much.
Can see the white, that is a stapedius tendon, okay? In the red color area, you can see that is the stapedius tendon. Okay, all of you see that?
Yes, sir. Yes.
Sometimes you can get the contractions while they're doing the testing also. ISRT can do. 1 minute, 1 minute. Okay. Elicit. Okay. It depends on the depth of the anesthesia. If the anesthesia has given the muscle relaxant in the recent, we can't get this reflex also. Okay.
Okay, sir.
Okay. There is a finer movement, but we cannot appreciate because of there is a small movement over the blood vessels only. I can see it, you may not appreciate. Okay, complete the remaining tests. Yes, yes. No. Tissue. First object. Here also one more technique of sealing the electrode, fixing the electrode. First layer, these are 3-layer technique I used to call. I used to push the gel foam all around first. Why? Because I will explain. A small piece of the gel foam all around the round window niche. To slippage of the tissue outwards, that's why I will keep the gel foam first as a first layer all around. (360°) I will push the gel foam, then the tissue. See, the gel foam prevents the slippage of the soft tissue seal away from the round window niche. This is the second layer. This is my technique only, not described anywhere. Oh yes, definitely. Contact gone. Now I will do with the third layer, the Surgi cell. It keeps the tissue intact without doing just like a cementing. One more. All around the electrode. All around the electrode only. The soft tissue has to touch the electrode, not the gel foam or Surgi cell. Soft tissue. I am sealing the abnormal pathway we have created posterior tympanotomy. Always seal everything totally. Some of the surgeons, they may not seal this area, they will keep like open, but I use it to seal with the soft tissue Surgi cell. Suction tube. Gel. Okay. Pardon? Odipoyinda. This is the problem with the. Okay, now we can see. Okay.
Sorry for the interruption. There is one I-10 car is obstructing the way outside.
Okay.
I-10
Contact వచ్చిందా?
number, any number?
Okay, they are going for the MRI testing. Split the camera, external and internal, microscopic camera and external camera.
92
Now I am closing with the antibiotic soap and gel
9292
foam because we have to finish.
9092
We shouldn't keep the chain in more
9092
anesthesia.
I10 car.
One more gel foam.
Yes.
Just I am closing the mastoid cavity. This is a very smaller cavity I have made, and also with the proper gel foam. And now I will place the soft tissue, the extra soft tissue, to cover the implant totally. Suction, petty suction, big suction.
And one more 9384. 9384 car. They are obstructing the traffic, it seems.
Again, you have to recheck any bleeding is present. Bleeding was not present. Depositor. I will keep the remaining soft tissue in the electrode canal and also the between the bridge and the electrode. It also prevents the mobility of this implant. Some of the surgeons will seal with this the bone dust. I don't recommend the bone dust. Why? Because it may cause the infection. The vascular tissue.
Sir, Raidu sir.
Pardon.
Meanwhile, we will be taking one lecture, sir, by Mohanreddy sir.
Okay, definitely. It is only closure, only 3 layers closure.
Yeah. We will
Just
be
you can keep the video. Sir can
picture.
talk to Okay, just I am suturing. The suturing also starts from the inferior pole. External camera. Okay, it's over.
Dr. Naidu, wonderful demonstration.
Sir, thank
Sorry
you, sir. Thank you
for
so much.
interrupting
so
your great job.
Sir, here the flaps, first we have to suture the inferior pole.
Yeah.
Then the anterior, then the posterior. Is a better one. Where I have given a horizontal incision over the tip of the mastoid, you can easily find out. Take the first bite in the posterior edge. Here also I am using only one suture material to close everything. This is the rapid vehicle 2328 number. You can use external camera. Cut. First the inferior pole. Why? Because to properly cover the implant, the flap sometimes may not yield up to here. That's why. Next the anterior part of the horizontal incision. Go some fast. Like this. Why? Because I want to show the double breasting. We have harvested the 2 layers. Sometimes we may not cover the properly from posterior flap. That's why we need the anterior flap. Posteriorly I am closing this one. Lagu, targa. Rala. Retract.
So,
You can start your lecture, sir. They can show the video in one part, PIP.
yeah. Good morning, everyone. First of all, thank you, Harsha and Kishore. I think it's a great beginning you made, and thank you for the privilege given to me. Sorry to say, one of my very close friend passed away. So I had to go to see them at home to 2 o'clock, 2:30. I had to reach there. We are very close friends. He's Dr. Pratap Reddy. He was our Gandhi Medical College president, our student days, and we are very regularly meeting often. And yesterday also I was with him in the hospital, and in the morning he passed away. So his body they are going to shift. He is donating to the Gandhi Medical College. So I had to be there with all our other Dwarak and all of us are going there. So I'll not be able to continue with the program later. I'll complete this talk and I have to leave. Sorry, Harsha, for that. I can't miss that. So now I'm going to talk on a subject which is not new anymore. Endoscopic ear surgery. See, most of you are here assembled are juniors. All of you must have heard about the new approach for ear surgery. I hope every one of you heard? Yes? Yeah. How many of you are doing? Few of you are in touch. I'm very happy to see like this. See, this endoscopy approach for the ear surgery. We know that microscope was there since 1950s when the binocular microscope Charles Zeiss developed a wonderful microscope in 1950s. The otology has seen a turning point. So since then, we were using the microscope. I was also using microscope in ENT hospital for till nearly 15-20 years. I practiced with the microscope. I was one of the few to start with the endoscope in the sinus surgeries. So one day I just wanted to see, and I found it is useful, and then I started doing in way back in 1980s, and I found it very useful. But since 1980s, we were doing till 2015. There was no big attraction. Mostly because our seniors were reluctant. Why should we have another endoscope when we are doing everything with a microscope? Those were the comments which we used to hear. So that's how we began. And here I'm going to give you some of the glimpses of advantages of endoscope in another great tool. It's a tool, no? It's another wonderful tool with a great illumination, magnification, and hidden areas we can see because it provides an angled view. Okay, so it's another tool. Why should not we make use of it along with the microscope? We are not discarding the microscope. First of all, I want to tell you that. So we are using it endoscope for all the middle ear surgeries. Out of all my otology practice, 80% I use endoscope exclusively. Remaining, I use endoscope together with microscope, never alone microscope. So with this, I will give some of the tips and some insights probably which may help you and instill some inspiration for the new approaches. So going to the historical aspects, you see, the ENT took a long time to become popular itself as a separate specialty. When we were doing post-graduation, people used to say, what is there in ENT? ENT is tonsillectomy, central washes, and all. Nothing more is there. See, but the anatomy, deep-seated areas, the ear, nose, and throat, the anatomy is deep-seated in the bodies. So naturally, it attracted the attention of many scientists. Way back in 14th century, people have started working on dissecting the ears. All of you are familiar with the Eustachian tube, and Eustachius was the scientist, and Valsalva was the scientist, and Vesalius was the scientist in 14th century. After the Renaissance, they started dissecting the bodies, and they started dissecting the ear. They described all these structures, which we still find it difficult to familiarize ourselves, even with the microscopes. We are finding it difficult to get the 3D orientation of all these structures. It's a great, that picture I have taken in Italy, in Bologna, our second conference of endoscopic ear surgery. I visited Bologna. Bologna is the place in Italy where these scientists all worked on the anatomy of the bodies. So the deep-seated areas, they definitely require new tools, and the endoscope approach definitely helps us to reach to these deeper areas much easier because it has provided a natural passages also. Coming to the historical progress of the ear surgery, see, we all know the William Wild's incision and all, post-oral incision. He started surgeries for the ear by making an incision drainage of the abscess, mastoid abscess. That was how the surgical approaches started, by William Wild. William Wild was the brother of Oscar Wilde. You all know Oscar Wilde. And William Wild is also knighted. His brother is an ENT, so a specialist to those times, specialized in ENT practices. So all the surgical branches were together. All together they used to do all the things, but some people focused on the ENT kind of things, and like these people. So, of course, the instruments, tools make a lot of difference for the intricate anatomy to explore these narrow areas and minuscule structures. So it all started with the trifines, then the goose and hammers, and then later drills have come. That's why Murdy described the history of ear surgery in 3 periods, like, Tripan period, goose and hammer chisel period, and then drill period. So after the exploration of exploring the visualization for visualizations, the speculum started with the speculum. So I started naming this period of visualization into speculum and loop period and microscope.
Small thing.
And now I call it as a era of endoscope for the ear surgery.
Hello.
Yeah.
Sir, sorry for interrupting.
Yeah, right.
We did the primary closure with a superior base musculoparietal flap. We achieved the watertight seal. Now we have the second flap. See, this is I have harvested anterior based flap. It covers the entire area without exposing any suture line. You can't find anything happened there. And all the skin suture goes like that. This should not superimpose. Okay, sir. You can carry, sir. After completion, I will show again. Thank you, sir.
Okay, wonderful. Great. Applause, please.
Sir,
Great
no,
applause. Super Raidu.
Sir.
Yeah. So, after William Wilde and those surgeons, after the advent of the microscope, monocular microscope, it is William House who pioneered the otology with the monocular microscopes he started. Then the binocular and the advanced microscopes have come, now the endoscope. So these things made a lot of difference in the progress of our otology. The endoscopes history, if you take a little bit about the history, it all started with Mogini in 1806, when there was no electricity. So with the oil lamps and the natural light, they designed the scopes like this to visualize through this and passing into the ear like this. So then the sinus endoscopy, they attempted in 1922 by endoscope. Then up till the rod scopes have come, rod lenses have come, till 1960 there was a gap again. Then Hopkins rod lens has made a lot of difference. Then people started using the urology, and then Messer-Klinger and all these people started the era of endoscope in ENT. It has launched, Messer-Klinger is the pioneer in 1978. He started using the endoscope and published a paper. Later his assistant, Stambager, popularized worldwide the endoscopy approach. And in 1987, he came to India in our Asia Oceania Congress. I was one of the first few people, lucky people, to be there attending the Stambager's lecture. And I took up immediately in 1989, I presented my work, nasal endoscopy, a new era in ENT, like in an IMA meeting. So see all three, how we are seeing that through the endoscope we are looking into the structures. There was no camera at that time. Later, the endoscope cameras have come. So that made a lot of difference again. So this is how it has progressed to the orbit, and all the areas of ENT we can do now with using the endoscope like this, to the skull base, and the Janaki Ram and all pioneered in the intracranial approaches to these through the skull base. So the question is, can we expect the new millennial generation to accept cavity problems for the lifetime? That is a question haunting us all these days, even now. So in the words of Mirkotas, 100 years later, the creation of mastoid cavity still remains the main mode of treatment for cholesteatoma. So these are the desperate words because of the cavity problems we come across. So the minimally invasive techniques have come, and why not we try to use endoscope for eliminating cavity? That's how it all started. So coming to the mastoid surgery progress also, classification. If you see the classification, there is a simple Schwartz technique, Schwartz simple mastoidectomy, to the Bondi's modified radical mastoidectomy, and then all the cavities used to come, and the cavity problems continue to haunt. So we tried to answer that with the era of endoscope in the otology. And I started how I started is in 99. I presented my work in our national conference in Cochin. So these are the people who started at that time. I found in Medline some of our friends like Tarabici, Marcioni Daniel, and David Portier from Canada, and Stéphane Ayasi from France. All of us joined together. When I called Tarabici to India in 2005. Together, both of us conducted a workshop on endoscopic ear surgery. Then we all of us met. We formed an international working group on endoscopic ear surgery, like that, international working group on endoscopic ear surgery. In 2008 in Italy, we went there and we formed a group. So we are now popularizing it. But till 2015, we had a problem of resistance from the world over, from the seniors. It was not taken up by many. But by that time, juniors were getting attracted all over. Since 2005, we were conducting workshops like you, because it is easy for the juniors to pick up anything new. For the seniors who are used to, like us, changing is very difficult. So that's how it started progressing very slowly. After 2015 World Congress, first World Congress in Dubai, and later I conducted a first All India Congress in India, and now it is all over the world spreading, and people like you youngsters already are handling the endoscope. We feel proud for being the part of the progress. So why endoscope? See, this is the truth. Even the great sunlight cannot reach the corners. That is the main thing involved. So endoscope makes the surgery minimally invasive. The two main things. So to make it minimally invasive and to reach the hidden areas, endoscope made a difference. That is the main principle involved. Now coming to the tips and some of the tricks in endoscopic ear surgery. So as I already told, it provides enhanced visualization, and we have to adapt to some unique tips with experience to get a great outcomes. So endoscope is a new tool. Naturally, you have to learn a lot about the tools. Always when a soldier goes with a new armamentarium, he should know about the gun or whatever it is he is going to the war. So you have to get used to the tool. When you are using a new tool, you have to know about everything, and then only you will get a success. So understanding anatomy also, pathology also, changed with the new tool, with a new approach. We could visualize the pathology more clearly. See the anatomy, which we studied in Scott Brown, basic sciences. Those days, way back, it was described, all these mucosal folds and the medullary mucosal spaces like this, all the inguinal spaces and all those mucosal folds in the medullary cavity, the small area of 2 millimeter diameter divided into various compartments, all are described by the great pioneers like Portier and all those people way back. So we studied them, but we never used to see those structures more clearly till the endoscope has come. So if this is the key medullary structures, how they look with the endoscope. See that is the malleus and the incus, IS joint, and the stapes, and this is the key isthmus tympanicum, like osteometal complex in the sinus, lateral wall of the sinus. This is the key functional area, isthmus tympanicum. That is the key functional area there. So all these structures and medullary spaces we are able to see very clearly nowadays, and that made a difference for us. So we have to always memorize the 3D anatomy in our mind when we are doing endoscopy, ear surgery, for that any surgery always. So these are some of the surgical pictures. This is the opening into the tensor fold through the adductors. See, this is the body of the incus. Underneath the body of the incus, through the adductors, I can see the tensor tympani tendon here. And that is the posterior mesotympanum area. And this is, as I told you, isthmus tympanicus, incus IS joint, stapes. And for the junior sake, I'm going in detail. So all these anatomies, this is the adductus area from behind my dissection. This is the superior incudal space, incudal fold. If I remove, then it appears like that. Anteriorly, there will be cog, and the malleus head will be attached with the superior malleolar fold to the cog there. So that separates the anterior aortic space to the posterior aortic space, posterior superior aortic space here. Under the body of the incus, you can see the isthmus posticus coming and connecting to the through the adductus into the antrum. That is how the pathology spreads like that. So when we take up for surgery with the endoscope, we have to always, preoperatively we have to do otoendoscopy, get the idea about the different pathological appearances, get a clear idea about the medullary mucosa, all those things. Different pathologies appear differently, and we have to have in our mind before only when we do otoendoscopy, the roadway for surgical approach.
Sir, sorry, so sir, finally we are closing everything. Just see the suture line. Are you able to see the axial camera? Are you able to see the axial camera, sir?
Yes. Yeah, everybody. Everybody can appreciate that.
And also
beautiful
the receiver stimulator here, the same line.
Yeah.
And also we put the subcuticular suture for everywhere, sir.
Correct.
Because the 5 minutes extra time gives the lifetime scar for the kid.
So nice.
We can't find out the scar later on.
Sir, great job.
Thank you so much, sir.
Yeah.
Thank you very much. We can go ahead with it.
Yeah.
I will explain the dressing later on after coming upside. Okay. Sorry for interrupting you twice, sir. Thank you.
So, depending on the pathology and the extent of the disease, we design approaches, transcanal approaches most of the times. So, we have to design the flaps also, depending on the pathology. With our own experiences, we can design different flap techniques. So, the CT scan helps us to see the soft tissue shadow, which is medial to the ossicles here. So, we have to work medial to the ossicle area, transcanal. When we are going there, probably we have to deal with the ossicles there, which is the disease is hidden behind the ossicles. So I may have to remove the body of the incus or head of the malleus like that. I have to keep some idea about that. See the depth of the sinus tympani also classified by Daniel Marchioni. You can all read that. So different kinds of anatomical variations will be there. The facial nerve here, the facial nerve and the relations with the facial nerve and the sinus tympani. All those things we have to keep in mind when we plan for the surgery before only the otoendoscopy and imaging and all. So coming to the patient positioning, this is a table we arrange like this. So we have to ergonomically place the table and the endoscope camera. See the camera there, and then the surgeon quite oppositely, at the parallel to our eye level. Then the assistant will be there. Very important to have a very good trained assistant in endoscopic ear surgery, because we will be viewing at the monitor and doing the surgery with our hands like this. So a good assistant makes a lot of difference. If the assistant is not experienced, it will be miserable. You can't do the endoscopic ear surgery. Because when we ask for the scissors or when we ask for the crocodile forceps like this, they should give it correct into our fingers to fit our fingers into the forceps handle. So like that, the assistant makes a lot of difference. So the suction also, they have to block in between now and then, and they should know when to block, when to release, because a minimal amount of bleeding also makes a lot of difference and it creates problems. So the patient position, anesthesia, head turn to the other side and 15 to 30 degrees lower, the head end should be lowered so that we can visualize the attic areas more clearly. When we lower the head end, we will see the attic area more clearly. So general anesthesia, I do only when I require drilling the mastoid. That means mastoid when I have to open, we do. Otherwise, I prefer local anesthesia for all the middle ear procedures because it helps me to check patient's hearing on table and getting his responses. So in ossicular reconstruction, when we put the graft, cartilage or whatever it is, if the ossicular reconstruction assembly is good or not, I just touch the tympanic membrane and ask him whether he could sense the sound, movement by movement of the very slight gentle touch also they should hear. That means our ossicular reconstruction assembly is in right place. Like in stapedectomy, we all know, we ask them to respond to the hearing and all. So the equipment also, when we started with the endoscope in the ear, when I started, there was no standardized procedure described by that time. I started after my sinus surgery, endoscopic sinus surgery, one day, let me see the ear with the endoscope. I was thrilled to see the eardrum so clearly, so panoramic view. And later, one day I start, let me do a surgery also with the endoscope. How to go, how to hold the endoscope in the ear, how to hold the instrument, that was the biggest problem. See, but then I thought laparoscopic surgeons, how they do. They pierce with a small hole, a keyhole in the abdomen, and they put the scopes and another hole in the another part, and they pass the instruments. So it struck to me, let me do like that. I thought of pushing the trocar, the trocar for the sinus surgery I have taken, and I posteriorly, in the postauricular groove, avoiding the cartilage, I pushed the trocar there into the ear canal. And then I put the endoscope there through that. And how to hold it? I sat on a stool and I used to hold with my abdomen. I used to do the surgery with the both hands. That helped me a lot. But the dynamic movements I could not do, no. So later on, let me start doing with the endoscope, holding it with one hand in the ear canal, and then I started doing it. So gentle movements helped me a lot in completing the procedures. By 2004, I have done all the procedures of middle ear surgery, cholecystectomy, meringoplasty to ossiculoplasty, cholecystoma, stapes surgery, and all those things. 2004 state conference, I presented 105 or so cases of stapedectomies with endoscope. And 2010, when I went to Italy, I presented my work of the difficult situations in stapes surgery and how to deal with the difficult cases in endoscopic stapes surgery like that. Everybody appreciated. So the instruments I have taken to Italy are these instruments. See, the suction cannulas you see there, I have bent the suction cannulas which are available in the microscopic ear surgery. At the tip I have bent because I could see the angled view into the posterior tympanic recesses, but my suction doesn't go there. I could see on the monitor, so I have bent. That's how I got the idea to bend the suction cannulas. Then I felt so great getting that idea. See, these ideas we get when, like Archimedes, So the ideas make the difference. So simple things only, not a big, great thing, but till the idea comes to our mind, we'll be stuck doing the same things always. So our practice makes us, get new ideas. That's how we took the instruments. One day one fine pick fell down and it got bent, and now also I find that is the best endoscopy pick, ear pick. I use it. Shravya knows, all my students the juniors who work with me know that pick. I always ask for that pick which got bent with double bends. So I have taken that to the Italy, I have shown them. So our group asked the storage people to make a set for endoscopy ear surgery with all these bends and curves, double curves and all, and the finer instruments. They made a set also, but I use my own set always now because I am used to that. So the anti-fog solution is also very important, and camera makes a lot of difference. So always we have to start, when you want to begin with the endoscopic ear surgery, you have to begin with OPD procedures. The people, the youngsters, when they come to me, they know that how much I ask them to do OPD procedures first. Ear cleaning also. I found, I am telling you all now, I found all of them who come to me, they were not doing a proper ear cleaning or wax removal also with the endoscope. They learned in my place how to do that finer tips I used to give, and they will be very happy after that. So always start with the OPD procedure. There is a foreign body insect. I just used a suction cannula and it came out through the suction like that. But the foreign body insect, moving one, that will be causing lot of annoyance to the patient. So immediately you can ask them to put the oil. I think that's the only place where I suggest oil. It kills the insect by suffocation. Later on you can remove. So the other procedures like foreign body, the cotton wick there, and then grommet insertion. The endoscope is the best for grommet insertions we found. And the tiny ear canals, external ear canals with the kids, small kids. This is the best technique. In 3 to 5 minutes we can finish, but it will be a mess if you touch the ear canal with the suction tips. If it starts bleeding, without touching the ear canals, you have to reach the site of the incision in the eardrum. You can see the vascularity of the eardrum. Between the vessels you can make a small opening and you can push the grommet with a two-flanked grommet. It always will be useful. But if you don't get used to putting the endoscope in the ear canal and handling the instrument with the other hand, you may touch inadvertently the ear canal and start bleeding. Even the grommet insertion, which I say it is the simplest and the best, it becomes a mess. Sometimes you can't abandon also. So you have to avoid touching the ear canal. So coming to the myringoplasty, which I wanted to demonstrate today, I could not. See, this is a very interesting case I found. You see, there is a very large perforation. So with the double bend pick, which I am using, it provides me the curve to avoid touching the ear canal and visualizing the tip also very clearly. So I make a curvilinear incision in the ear canal to raise the flap. See beautifully, you see this is the oval knife till I reach the annulus, identify the annulus. Then I check the ossicular chain, that is the incus I am touching. You can see the resistance there. I found it is more stiff like. It is not moving as I wished. It is not easily moving, the ossicular chain. It was a central perforation. Patient came with a 50 decibels, around 50 decibel hearing loss. Anybody, a dry perforation, central perforation, small or big, comes with around 45 to 50 decibels around that, think of ossicular chain fixation. The most common site of ossicular chain fixation I will show you in this case is one of the first few cases I have done the mobilization of the malleus to get the best result out of it. So see that stiffness you feel there. See, this is the facial nerve there. That is the tensor tympani tendon. And see, now I have extended my incision anteriorly further to reach to the anterior malleolar ligament. There I am releasing the malleus. See that? By removing a sclerotic tissue there. Then mobilizing the malleus from there. That is the commonest site of ossicular fixation, the malleus I found in these long-standing central perforations with a 45 to 50 decibel loss, think of this situation. See that I have mobilized the malleus like that with a small window there. This is not possible to do with the transcanal with a microscope. This finer maneuverings, I found it very difficult through the speculum transcanal approach with the microscope. See, though it appears simple, I could avoid the post-oral incisions and soft tissue dissections. See, such a beautiful, very close view I got. See the movement now? The stiffness has gone. And the patient got a very good hearing result. Even now, he comes to me with a happy face always whenever he comes to me. He was a politician. And see that mobility. Very simple technique. We used to graft such cases and leave them alone like that. Now also I see many people doing that way only. But whenever you come across with a hearing loss of 45-50 decibels, think of malleus fixation. Though they appear all normal, like check the mobility, stiffness, and if you are not happy, mobilize it like that. See, I put the graft like that, and I use a air bubble technique for the graft. I don't put gel foam in the middle here. Very few times, where I find very necessary, then only I use the gel foam. And I'm pulling the graft through the anterior pocket which we have created to ensure more secure graft placement there. And then I lift the graft with the angled picks, and the air in the middle ear lifts the graft up, and the surface tension, see that? The surface tension provided by the graft and getting at touching the tympanic membrane remnant or the annulus, the surface tension holds it up. And that's how, see, I'm pulling the graft through the anterior pocket there to create an additional support. And the graft is pulled like that, you see, nicely lifted up. That air bubble inside the middle ear lifted the graft, and the surface tension all around holds the graft touching the annulus or the remnant. That's how it will hold, and it doesn't fall. Very few occasions where I feel I need additional support, especially in the anterior superior quadrant or posterior superior quadrant, I put little gel foam. Sometimes where there is already a retraction, a case of retraction pockets, naturally there is a compromise in the middle ear ventilation. So I put a cartilage, small pieces of cartilage, not a big island graft, small piece of cartilage in the posterior superior quadrant, where to prevent retractions again forming, reinforcing the area. Sometimes I put an island graft, sometimes with a small central perforation, a small island graft only cut through the perforation. Underneath we put a gel foam. Sometimes I put two cartilages or a bigger cartilage with a V-shaped cut to support. It depends, there is a collapsed middle ear, a retraction pocket, I put cartilages in different ways, depending on the case. Understand? This is the post-op, and the hearing also is improved. You can appreciate that. Now another case, there is a posterior retraction in this case. How we do that, you see that. See that a retraction. Through the retraction you can see that is a malleus, this is the incus, IS joint, stapes, head also you can see. The membrane is draping onto the stapedius tendon and IS joint. It is draping onto the ossicles. There is already lenticular process, there is a small erosion there. Incus erosion, partially eroded. So there is a danger of ossicular necrosis and discontinuity in future. In such cases only we operate. If the retraction is small and the hearing is good, in those patients we never advise immediately any surgery, if simple retraction. If there is already adhesions and retractions causing adhesions and erosion of the ossicles, To prevent further damage, necrosis, ossicular necrosis, you have to do a simple technique, simple approach for the retraction pockets, endoscopy approach. So you can do a very good job like that. And you can put a cartilage reinforcement there. You see how meticulously we can tease the adhesions from the IS joint. See, nicely with a crocodile forceps, you can tease and separate the adherent membrane from the head of the stapes, from the stapedius tendon, ossicular IS joint. You can pull it up. You can see the very close view you can get, and we can pull it carefully, nicely like that. Since I'm not able to demonstrate the surgery, you can see that the same thing, how we do like that. See, that is the oval window there. And this is the pyramid, stapedius tendon, IS joint area. Carefully use the crocodile forceps to hold it and peel it like that, gently, from the ossicular incus. See the endoscope giving a close view like that, and all the surrounding areas all in one field. It makes our job easy. With the microscope, to get such a magnified view, you have to increase the magnification, and you will not get a panoramic view. Only the focus of a particular area will get. And transcanal like this to do with the speculum, it is still more difficult. I think it is very difficult. See that entire retraction pocket is cleared off from that ossicular chain. Now that is the isthmus tympanicus anticus. That is the tensor tympani tendon I am touching. And that is the ventilatory pathway to the anterior attic. From the eustachian tube here, the ventilation comes into the under the malleus, and then through the isthmus tympanicus anticus, it goes to the anterior atticus, and from below the body of the incus, which I have shown, into the adductors, the ventilation goes to the adductors in the antrum. That is the ventilation. See the cartilage piece I told, no? The small cartilage of the pericardium. I am keeping it there because it's a already retracted pathology. So reinforcing the membrane there. That's how I use. There is no standard fixed this thing. I use only the cartilage for tympanoplasty. People are talking like this nowadays. If they are happy, it is very good. Let them continue. But you need not take every word of every surgeon, including me. That is the best like that. You need not take like that. Ultimately, after seeing various methods, various techniques, various surgeons, tips and tricks, you will ultimately adapt your own methods. It is like driving a car. So you learn from watching the people, many people, and you learn. But ultimately, you will learn your own way of driving, isn't it? That's how you will also come up like that. It's only you have to watch. Never take it like that. This is the only way you have to do like. This is the best like that. Nothing like that. It depends. The best thing is the best thing for this particular case, particular pathology, particular situation, and your experience. That's the thing. Always you will take. So coming to some problems like this, here you see a small central perforation. People think it is very easy, but removing the remnant margins of the tympanic membrane is not easy in such cases. It will be flabby tympanic membrane, and you can't cut with the sickle knife. What to do now? See that how I am doing? I am puncturing the tympanic membrane with the pick, sharp pick, and attaching them carefully. That's how we can see that. I have to puncture it repeatedly and attach it, connect it, puncture and connect, because the membrane will be flabby. So these are all you can get an idea by seeing this. So this is how, when you do first time, you will be worried. You will be wondering how to do, what to do like that. So this is what I wanted to give you an idea. So now coming to depending on the pathology I told, I design the flaps. Sometimes I design a double flap like this, sometimes I design a flap like this, and circling the pathology, that's cholecystoma. and then I do the mastoid, open the mastoid from behind, and through the adductors I do the clearance, and from the anterior tympanotomy I do the clearance, and that's how we do. It all depends on the pathology and where is it. Most commonly, when the perforation involves the posterior annulus area, the posterior canal, the perforation extends, or the granulations are there, or the disease extends posteriorly into the up to the canal, I design double flap because it provides a wider view. This is a fish design flap. Way back they have described. It's not my own, but with the endoscope I have adapted it for the best use. So coming to the bleeding part is the biggest problem in endoscopic ear. If anyone wants to do endoscopic ear surgery, you should have absolutely bloodless field. Even a drop, a very small tiny drop will hamper your work, and you will be, you will be like feeling like a burning, nuisance like. So the bleeding is the biggest issue. So to have a bloodless field, it starts from preparation of the patient from the before, like endoscopic sinus surgery. So you have to control the infection, inflammation of the, if there is an external ear canal skin inflammation, you have to attend to it. Most of the times you will find in CSOM cases inflammation of the external ear canals. You have to treat them before with them antibiotics and drops and meticulous oral toilet and making them come again for some time till you get a satisfactory ear canal skin uninflamed or a reduced inflammation. Then you have to use the hypotensive anesthesia, and you can ask your anesthetist. Then the adrenaline infiltration. Only two parts of adrenaline infiltration I do. One is incisura terminalis area. I poke with a 26 number needle, 1 inch needle, 2 cc syringe. I take about 1 cc or 1.5 cc of xylocaine adrenaline, 1 in 10,000, and I put a poke into the incisura terminalis area, and then I put in the floor. That's all. If you get a good blanching, that's the 2 spots enough. If you do more poking, more bleeding. So to avoid that, I found only 2 spots is enough to get a good anesthesia. About a half cc here and a 0.2 cc somewhere is enough. More than 1 cc it will not be required many times. See here, the other case which I have shown, there was no bleeding, but here you see, I started getting a lot of bleeding and all. See what I am doing? I am pressing my suction tip against the bleeding spot. And I am using cotton balls liberally. See, there are 2 cotton balls. I put on more cotton ball there before, and I got the blood. And you have to be patient sometimes. You have to wait for the blood to stop. Keep the cotton balls soaked in 1 in 1,000 adrenaline directly, and use the cotton balls. See that how I am lifting the annulus lower down towards the hypotympanum using the flag knife or right angle knife. Once I reach the middle ear, then against the annulus you can dissect it and move it. So you can see up to the hypotympanum, up to that by tilting the endoscope very clearly. With the microscope transcanal you can't see sometimes the hypotympanic area of the annulus. So very clearly you can see. If there is bleeding, repeated irrigations of warm saline or normal saline also, regular, you can, it will help you, irrigation, and it will wash up the tip of the scope from the blood, and then it will provide a clear view. Once you enter the middle ear, we found the bleeding will not be a big problem. Before we enter the middle ear, then only the bleeding, till we lift the annulus. Once we lift the annulus, bleeding will not be a big issue for us. Till we lift the tympanomeatal flap, that time only you should have a bloodless field to continue. That is the time till the lifting of annulus. That is the time which will be more cumbersome if there is bleeding. See, I have put another cotton ball there like that. You see how I am managing the bleeding in a case like this. Sometimes, with a good anesthesia and all, they won't be bleeding. But sometimes you will still get bleeding because of inflammation or pathology there, due to pathology. See, there is a bleeding spot in the bone there. See, I am pressing against that bone, that bleeding spot. See how I am using the suction tip to press it and hold it. So the idea I got is from the pressure you can stop the bleeding. Anywhere in the body when there is a surgeon, there is a bleeding, they put the gauze piece and all. Here what I should do, if I have to put a pressure from the bone bleed, I crush the bone there with the tip like that. These are some of the tips I wanted to pass on to you people like that. See, I have lifted with the cotton ball I am lifting the flap, you see that, using the cotton ball and suction also. Same time clearing the bleeding and using the cotton ball against the flap, to elevate the flap also. You can use that way. But with experience only you can probably do these maneuvers. So there is advanced surgeries. You have to go for stapedectomy kind of things. Only after you learn all the maneuvers, all the techniques of handling endoscope without causing injury to the external canal, without getting bleeding. Once you get confidence of anatomy, once you get confidence of doing kind of things, safely, then only you have to take up surgeries like stapes, because stapes surgery can be, a very, very risky surgery, because the patient can go for a permanent deafness. So youngsters, you have to learn on cadaver, you have to learn, go through the workshops and all those things, then you can take up. Don't jump to the stapes kind of surgeries immediately with the endoscope or microscope, whatever it is. So that's how the stapedectomy is done. I remove the stapes. There is a suprastructure. You can see the two crura and the head of the stapes coming out. And then I use a graduated perforators for making stepidotomy. So there is a different ways of doing stepidotomies. So this is the best I found, and useful in the sense I'll have a tactile sensation also on the foot plate. Only I find it difficult when there is an obliterated otosclerosis, a very thick foot plate. Then I use skeeter drill. I have a skeeter drill I use and make a pit. Then I use again perforators. I'm not a big fan of a laser. Because the laser is one thing is costly, and the manipulations with the microscope and all those things, it will be very cumbersome, and it doesn't provide the tactile feel. In the laser also people do different punctures to avoid heat in going directly into the vestibule. So coming to some challenges I told, fogging, and then we have to narrow canals. So we have to switch to the 3 mm scopes also available now. They will provide, by even 1 mm diameter of the scope makes difference. So the post-operative care, you have to put gel foam on the ear canal. I use very sparsely gel foam always, and early follow-up, careful follow-up, 1 to 2 weeks. And gel foam you should not disturb till 3 to 4 weeks. You never disturb, and look for any infections, external canal infections. In our country, fungal infections are very notorious. You have to be always watchful. So now coming to the new inventions, endoscope helped us to go for innovations. So this is a tool designed by the Chinese company. It's a plasma electrodes. They have come out with the plasma electrode. That's a tool like oblator with a round knife like. They use it. We can use it, but it requires further improvisations. I have used it and seen it. And there is a piezo device to remove the bone without damaging the soft tissue. They are all useful, but they will be of a limited application, like a small bone removal, bony canal, scutum, or posterior canal, but very useful piezo. The plasma electrodes also very useful. If they come with improvisation, definitely we will be happy in future. Coming to the robots and AI, all these things are going to be of your take in future. You are going to be the masters for these things. You should be happy for all these developments in future. So coming to these statements like microscope or endoscope, like Nothing like that. We are not surgeons of a tool, we are surgeons of the ear. You have to remember, make use of the best of the both. Whichever you feel comfortable, make use of it. But I feel endoscope should be always used in the ear surgery, even though a microscope is used, because it provides additional visualization and clearance of the disease. And there are good number of studies where endoscopy is used for the narrow recesses like sinus tympani, facial recess, and the small middle ear recesses, the disease which used to be left behind by the microscope. Even the best hands of the microscopic ear surgeons, like who never want to take endoscope, they have studied again using endoscope, clearing some amount of the disease which is left behind, and getting better results and better recurrence-free rates. And one more thing is, improvisations are possible with the endoscope, new tool, naturally. And the canal down, canal wall up techniques, cavity elimination techniques are possible with the use of endoscope. So the take-home messages, endoscopic ear practice, some of the things which I want to tell you is it's a graduated approach you should adapt, and then attend conferences and OPD endoscopic procedures first. Eye-hand coordinations, I think you people are the generation of computers. You will have a lot of experience with the games. You will be the best endoscopic ears. It's definitely, because you will have already hand-eye coordination with the computers and games. So start with the simpler surgeries and go for that, bigger surgeries. So in the words of Karl Marx, the great philosopher, and how many of you have heard of Karl Marx? Many, all of you, either good or bad. You may have opinions. This is what Karl Marx, 18th century philosopher, social, political, and economic scientist, a great revolutionary who made a change in the world outlook. He, in his words, this is the best statement we should take for us. We can also take tools and minds bring the change. The tool makes a lot of difference, but our mind also we have to apply for that. So thank you very much.
Those who are regularly doing endoscopic ear surgery will realize that sir has given extremely valuable tips, because when we actually do the surgery, we encounter roadblocks. And so sir has shown in a very beautiful manner how to overcome those, those problems, like for example, bleeding and the canal getting, the endoscope getting fogged, the vision getting fogged, and how to overcome that, and how to achieve hemostasis, and how to use angled instruments and suction tips to negotiate and take out disease. So, all of you all are, it's audible, I think. So, how many of you all present in this hall are doing endoscopic ear surgery, just for an idea? So, 50%, 50%, so that's a very great thing. So, I personally wanted, I wanted to clear a doubt. So, when you're doing drilling, for example, when you're doing dichotomy or inside out, in case of limited cholesteatoma, so you're holding the endoscope in the left hand and you're holding the drill in the right hand. So how do you manage to do the suction? Because normally when we use a microscope, we have the suction in the left hand, we are taking out the saline and the debris. So how do you do that? Do you ask your assistant to do the suctioning?
Yeah. See, a good assistant will definitely help us. But no, transcanal or endoral approach, drilling the bone, we should not attempt to drill the bone, too much of bone with the endoscope in hand. Definitely you are likely to damage your endoscope tip. It may touch. So you have to be careful, definitely. With the practice, probably we can handle the things. But skeeter drill helps. There won't be a big need of drilling a lot in the limited surgeries, limited disease, which is confined to the middle ear. See, I have classified the cholesteatomas into 4 stages. The cholesteatoma up to the horizontal facial canal is stage 2 I made. When it extends above the horizontal canal and into the adductors, it is stage 3. Then when it enters through the adductors into the antrum, that is stage 4 in my classification which I made. So stage 3 and 4, stage 3, you may come out completely with the endoscopy transcanal alone by using curettes. Sometimes I use chisel, a small chisel also. I have used chisel for the stapes surgery also, where there was an overhang, too much of overhang, which is covering the carda tympani completely, very hard bone. I have used chisel very carefully. Why should not I use it when people used before without getting injury to those things? Only thing is you have to have a dexterity and experience and confidence to use the tool. So like that, the bone removal in stage 3 cholesteatoma requires a lot of scutum removal. I use the curettes, very sharp curettes, and sometimes the goose also, or a chisel, and then I use the drill again, like that, to remove the small bone. Using drill, suction, irrigation, both are required. So there is no tool yet, all three combined. Drill, suction, irrigation, all three are not combined, came out to combined these things. See, even the plasma tool, the Chinese people are also, they have come with endoscope with irrigation model. And here they will have a suction to the plasma tool. So like that, there is no instrument till now. I tried to design with the suction cannula and all those things, but it yet to come. Probably in future we have to, all three should be combined. Yeah. See, endoscope holder, in my practice I am not using because I am used to regularly. One thing is it will hinder our dynamic movements. Subtle movements we feel like doing when you use the endoscope, hold the endoscope to see the narrow recesses. We need to do subtle movements constantly, continuously. So it will hamper, it will be fixed at one place. If you have a surgery like a continuous surgery for a longer time, where you can keep the endoscope in one fixed position for a longer time, you can use it probably, but once you get used to using with the endoscope and one hand surgery, you have to master it. Once you master it, you don't find it useful, or you may find it it will be hampering the dynamic movement. So we are not using it. Many people are also not using, but probably it has to get a robotic system should come with a holder which should move on its own where we are focusing like. Then I think it becomes definitely very versatile and useful.
That's the biggest disadvantage of the endo holder because it is fixed. Whereas actually when you're doing the surgery, you'll be inadvertently moving the hand and adjusting you'll be zooming in, zooming out, changing the angle of the scope to get a better visualization. So the dynamic movement is required.
Our hand has got so many joints,
without your knowledge,
see so many
you'll be
movements. That kind of a mobility.
So if you fix it, it becomes a disadvantage. Thank you, sir.
Thank you.
Thank you. We can start.
Sriharsha for that.
Yeah. So after lunch, we have two live surgeries. One is microscopic stepidotomy by Dr. Subbarayed sir and endoscopic tympanoplasty by Dr. Shakuntala.
for children or adults to get back their hearing and get into the environment, normal environment. So that I am going to present now. So when we see the difference between Anna screen. Anna. Yes. When it comes to 360-degree listening, there will be huge difference between single side deafness and when it compares to binaural listening. When there is like cochlear implant done at one side, again the other side is getting in shadow. So in that cases, what we can do is we can recommend bimodal listening to the clients, whereas now the latest technology have many artificial intelligence hearing aids and CI also, where we will be seeing what benefits the clients will be getting when they are going bimodal and when they are having unilateral cochlear implant. So as you can see in the slide, binaural hearing is always important to understand from different locations, whereas when it comes to single side deafness, when we are doing cochlear implant, still the monar cochlear implant, still the other side is deaf, other side is not having anything. So in that cases, if client is affordable, then we can go for bilateral cochlear implant, or if not, then to protect the residual listening, we can give the hearing aid to the other side. So let's understand what is bimodal cochlear implant, bimodal hearing solution for hearing impaired people, whereas bimodal will be one side cochlear implant and other side will be hearing aid. Now recent hearing aids have communication between cochlear implant and hearing aid, whereas there are two companies, AB and Cochlea. Cochlea have bimodal compatibility where hearing aid and the cochlear implant work together for streaming phone calls, streaming the accessories. For example, child is in the school, teacher can speak to child, he will be able to listen from cochlear implant as well as with hearing aid also. But obviously the listening, audibility will be more in cochlear implant than hearing aid. When we compare the scoring of both cochlear implant and hearing aid, obviously cochlear implant wins. But to make it live or protect the residual hearing, we keep a hearing aid at other side. So most common questions about the bimodal solution is what difference between cochlear implant and hearing aid. So yes, obviously there will be a difference between cochlear implant and hearing aid. When it comes to some pathological conditions, we will not be able to do cochlear implant for other side. So in that conditions like tumor and all, so we can do one side implant and other side we can keep a hearing aid. Yes. Second common question is, can I use a hearing aid and cochlear implant at the same time? The answer is yes, we can do that. And with that, there will be like in AB, there is a recent technology where we can give cross hearing to child, where other side also child will be able to listen if they want a better listening. And if we can give, if other side there is a less hearing loss, like mild, moderate hearing loss, we can give a hearing aid and child will be able to, child or adult will be able to understand perfectly. Third question is, what hearing aids are compatible with a cochlear implant? Yes, there are mid-segment and high-segment hearing aids which are compatible with 2.4 gigahertz wireless compatibility, just like our Wi-Fi connections. So within 10 feet of distance, they will be having compatibility with made for iPhone and made for Android, as well as with the accessories. So obviously, which one is better, cochlear implant or hearing aids? Yes, in some cases we say cochlear implant is the only option, but initially for 3 months we try for kids with hearing aids and doing AVT, auditory verbal therapy for kids. If this works, then we stick with the hearing aids, otherwise we go with the cochlear implant only. The fifth question is, does bimodal hearing solution really works for my children? Yes, it will work. And yes, obviously it will work for, it will help in long term, like understanding speech, improving the speech, then getting voice to the normal level. Obviously there is a study where cochlear implant children who has done a single side implant, and those who are using bimodal and those who are using bilateral. So there is a huge difference between when children are using cochlear implant in one side and children are using bimodal compatibility hearing solutions. So huge difference, almost 30% of the difference in their voice, speech clarity, understanding speech from different directions. So bimodal benefits, here we can see the graph which denotes with the yellow is bimodal hearing, and with bilateral hearing aids, yes, we are getting, obviously word recognition will be better with cochlear implant and hearing aid when we compare only bilateral hearing aids. So there are different scenarios and performance level where we can see clear winning with bimodal compatibility. So what are the major benefits of bimodal compatibility are speech recognition in quiet environment as well as with speech recognition in noisy environment. So for example, client is getting lot of sounds from one side and other side it is a silent, like for example one machine is going on, or there is something, somebody is making noise in right side and left side still works. It will help for clients to and work accordingly. For example, there are cases which we have seen is client is having monaural like one side cochlear implant, and when they drive they are tend to get accident so frequently because they feel sound is coming from one side only. Instead, when they have to take turn at left, they take turn at right. So those cases also are very complicated. In that cases, we can recommend, yes, you can go for bimodal. At least they will be having a localization of sounds. Music perception will be very good when we compare to bimodal compatibility, and nowadays they are having BLE Bluetooth low energy and classic Bluetooth in hearing aids as well as cochlear implant, which will give patients Dolby digital feeling with
normal suction.
Yes.
Sorry.
Yeah. OT. Okay. There are few studies which we can get it. Coming to the hearing aid, a Resound company is having a Enzo Quattro, which is their latest C5 chipset hearing aids are compatible with cochlear implants. Enzo is having a powerful flat 120 decibel of covering range in hearing and 86 decibel of receiver gain, which will be enough for children with severe to profound hearing loss. So what this will give benefit is crystal clear comfort and high quality listening, connectivity and direct streaming, and then more of convenient and remote and real time support where we will be having a cloud based programming. Advanced Bionics, Cochlear, Resound and Phonak is having real time, like for example we get lot of patients from Dubai, Kuwait, Qatar. For them also we are able to give services with cloud based programming. Sitting here in India, we can do all the things except touching their ears. So this will be like there will be variety of color depending upon the patient's choice and their obviously their area. With like few people like different color and they want it to be like Bluetooth. So we can give them a color according to their choice. So there are different accessories which will be directly compatible to the hearing aid. For example, client is fond of listening music, news and all. For them we can give a different accessory called TV unit, which will be connected to the TV and streaming will happen directly to the cochlear implant as well as with the hearing aids. So second, there will be a multi-mic where it will be more of used by teacher and parents. For example, student is there in a big hall, even at 30 feet distance, he will be able to listen whatever the speaker is saying. So there will be one small mic which will be carried by the speaker, and in hearing aids, patient's client will be directly listening the sounds. And these are again compatible with mobile phones, iWatch and other Android phones also. So they are having like iOS and Android compatibility with bimodal streaming, whereas both will get stream at a time. Now coming to the technology where we are getting in advanced bionics cross cochlear implant also, whereas in hearing aids we have bimodal compatibility with cochlear implant. Waterproof has started with AB and Phonak. So where clients will be having IP68 rating products to work with, and believe me, these are working fantastic. Clients are really happy with this, and we are providing day in day out with the such technology where now yes, I agree we are now into more of techno, like medical field, where we also have to speak more of technology when it comes to cochlear implants and hearing aids. So same as with explaining them about their pathophysiology and anatomy of the ear, same way we also need to speak about the technology, and we need to upgrade, taking ENT to the next level. Yes, that's it from my side. If anything is there, let me know.
Hello. Any questions?
Yes, sir.
Okay. Thank you.
Thank you.
Okay, good afternoon. Do you have any doubts regarding surgeries till so far, either middle ear cochlear implant? And also, if you are not asking, but I want to express some things regarding middle ear surgeries using microscope and endoscope. Both are complementary for each other. We should not not incline to the endoscope. Why? Because God has given two eyes. They have given the two eyes for give the third dimension only comes with the binocular vision. The third dimension, the depth dimension, won't gives by seeing the screen. Two-dimensional use, you get only the two-dimensional views through the endoscope. The third dimension will create in the brain by us only with the binocular vision only. That is the thing. To do the inner aspects, deeper issues, and also you can't get the depth by seeing on the screens. And also the movements. Why? Because to do the suction, to have the both instruments. Why for the endoscope, for the holder? Already we have the system to acclimatize, adopted for thing, to do the better things. Where the deeper areas, angled areas, we can use the endoscopes to clear the disease from there. Otherwise, my vote goes to the microscope only. To become a good middle ear surgeon, otologist, you have to develop the anatomy like the way of microscopic anatomy. In the endoscopic view, it provides the panoramic view. Okay. In the panoramic view, to deal with the micro instruments and all, we require the both hands also. That's my personal opinion. I'm not against for anything, but what I have developed, I'm doing because I love to do the ear surgeries more and more. In the last week, I have demonstrated at Kanpur to clear the disease from the sinus tympani by going to the posterior tympanotomy only. We are not disturbing anything. Through the posterior tympanotomy, we are able to clear the disease entirely from the base of the pyramid and medial to the facial nerve, everything easily. Like that. And also, any doubts in the cochlear implantation? I feel very difficult to do the cholecystoma than the cochlear implant. The cochlear implants, these are anatomy is clear, the physiology is functioning, only the internal ear is not functioning. The way we shouldn't disturb any anatomical conditions also. Following the principles, following the drilling techniques, it's very easier to do any other than the middle ear surgeries. And also these people asked for the stapedectomy. I'm feeling very stressful to do the stapes. Why? Because if something goes wrong, we'll create a sensory deafness to the functioning ear. Here having the dilated vestibular aqueduct, sometimes we may get the gusher, that's why we have cancelled the case. Those type of the cases should not do in the workshops. Why we have come over here is to alleviate your fear complexes, to develop something, to learn something from the workshop. Here you should not go with the idea, oh, I am unable to do here, we can't do this, we can't do go that. You should not think about this, not like that. Here is to learn something, some point to do, to practice in daily, in routine practice. That's why we are providing the simple surgeries here only. Later on also, if you have any interest, I am open invitation to come to my center. We do more cochlear implants and also others also. Anytime you can come as observer for short time or long time. And you want to stay for a long time, I can teach cochlear implants. I make you a cochlear implant surgeon. That is my side promise. Thank you.
Gauze piece.
Thank you, sir. So Subbarayadu sir will be visiting our center also for cochlear implants. We will inform through our WhatsApp channels. You can visit us whenever there's a case. So this auditorium was designed for that purpose. You put this wall, everything. It's a permanent setup. Within very short notice, also we can host any conference here. Our plan is to teach and spread the knowledge, and from now onwards we will be having regular workshops, at least monthly once. We will do it. Could be a small lecture to 1 or 2 day live surgical workshops we'll be doing regularly. So next, can we shift OT? Can we shift the screen to you?
Undi. Am I audible?
Yes, ma'am.
Are you all getting the picture?
Yeah, we are getting the external picture.
So I've harvested temporalis fascia graft. So I'll be doing endoscopic tympanoplasty. This is a middle-aged man with a dry central perforation and with moderate hearing loss. So I have harvested the temporalis fascia graft by a supratemporal incision, as you can see, and this is the graft. Is it visible?
Yes, we are. Yes.
Yeah. So then I have to spread the graft. So when you harvest the graft, basically this is what I follow, and that don't take a very large graft and waste the temporalis fascia. So basically the incision which I design is, you have to measure if this is the pinna, then your incision should lie between this and this, and about 1 centimeter above the pinna. Don't go too high up because you don't want to waste any temporalis fascia. In case if there's a failure or you need it for few such surgeries, then you'll have enough fascia in this area which is above, anterior or posterior. So harvest only that much graft which you require, and don't take any unnecessary graft. If you're planning a mastoidectomy, you need a very big graft, but if it is only tympanoplasty, it's a dry central perforation and mucosal disease, then you just harvest that much of graft that you need, and don't waste any extra graft, so that for future use you can have. So your incision should not be placed too superiorly. It should be just above the pinna, about 1 centimeter above, so that there is some graft left over, temporalis fascia left. So I'm just spreading the graft now, and I usually harvest a rectangular shaped graft. Why I do that I will show you as I do the surgery, and you will understand why I do that. So it should not, I don't take a round shaped graft, it's a rectangular shaped graft, approximately 2 centimeters width, and length will be about 3 to 4 centimeters.
Usually the graft size will be 1 square centimeter is enough, but the rectangle is always better than the circular. 1 square centimeter. You are doing for the open cavity mastoidectomy, you need the more graft, then the 3 centimeter square graft is required.
For a mastoid cavity lining, you need a bigger graft, as big as possible. But if it is only tympanoplasty, then I think this much graft is enough, which I have harvested. So I'll leave it out to dry. So this is how my graft looks, rectangular shaped. And if you want to measure, then it's about 1.5 centimeter in width and about 2 centimeters in length. So I'll leave it out to dry, and I'll achieve hemostasis in the area where I've harvested. So if you just want to see the incision, I will show you. So this is the incision. So if this is the pinna, so this is how I place my incision. I don't go anterior to the pinna, neither do I go posterior, and it is just above the pinna.
Sight is not visible, madam. Just focus, axial camera from above the shoulder of madam. Okay. Have you given the horizontal incision, madam, or the curvilinear?
Horizontal incision, and just above the pinna, so that all this area is left, which can be used potentially if needed. I should not waste graft.
Okay.
So I'm just cauterizing the raw edges. So this is very important. A meticulous hemostasis is important, so that post-operatively there is no hematoma which can lead to wound infection. We don't want any of that. So meticulous hemostasis is very important in any surgery for that matter. So I take special care in doing that. So the graft bed, if there's any oozing, then I just cauterize it. Okay. So I'll suture it later, and we can proceed to the main surgery now.
In the ear surgeries, the flap tissues are very important. That's why you shouldn't char the tissue. The pain also more post-operatively. Used to develop habit of using bipolar only whenever required, and also if you infiltrate proper way, you don't get any bleeding there. That's why the respect of the tissue or the bone is the mainstay for healing properties.
Top light should be off now. Okay, so I'll go to the endoscopic picture. So I'm using a 0-degree adult endoscope 4 mm scope, and as you can see that I have, before I harvested the graft, I gave local infiltration. After the local infiltration, before cleaning and draping, I put a long cottonoid soaked in 4% xylocaine with adrenaline in the canal, so that there will be some decongestion of the canal, because in endoscopic ear surgery you need to have a very bloodless field. So I've also asked the anesthetist to keep the blood pressure moderate. So the blood pressure is 108/73, and I have also asked him to give injection tranexamic acid, 1 gram. This is an adult patient, prior to the surgery. So it's been now 20 minutes, I think, sir, that we have given tranexamic acid. So I will irrigate the canal now. Cotton ball count in the brother? Okay. No, with that 2 ml syringe, just irrigation, saline irrigation. So whatever debris is there, I will irrigate the canal.
Anyone can answer? The elevation of the tympanic annulus, the remnant, what is the better point? Okay. Start elevation.
I'm asking the assistant to irrigate the canal. So whatever debris is there, that can be cleared out. So, so as you can see that it's a central perforation and it is dry, and even the middle ear mucosa looks pale. There are some dried secretions here. So just give me the round knife, brother. So this is one trick which I follow. So sometimes I try to
endoscopic picture, please.
Give me a dry cotton ball.
Endoscopic picture. Madam, we are not getting endoscopic picture. Please hold on.
Okay. Dry cotton ball, okay, 5 patches tight. Can you get? No? ఈ పక్కన లైట్స్ అన్నీ తీసేస్తారా? Too much of lighting is there in the theatre.
Now we are getting the picture, madam. We can start.
Yes, thank you, sir. So
the cleaning of the canal also important. We have to clean each and everything neatly.
I hope the picture is focused.
Yes, clear.
It's clear,
but
sir?
the mucosa is more edematous, madam. It appears polypoid.
Little bit, sir, because I believe when I asked the patient, I believe he had discharged 4 days back.
Okay.
So ideally, we would wait for about 2 weeks to 3 weeks after the last discharge. But apparently, he has been given a course of antibiotics and all, and the ear is dry presently. Round knife, please. So what I do is round knife.
Will you do only for myringoplasty, madam, or the cortical mastoidectomy also?
Sir, only myringoplasty.
Myringoplasty. Okay.
Yeah, please, sir. కింద చేయండి, క్లారాక్రోమా చేయండి, పైన పైన పైన, యా, వైట్ బ్యాలెన్స్.
The question for the elevation starts from the 9 o'clock position. Why? Because the periphery of the pars tensa, the circular fibers make as a cartilage, it forms the tympanic annulus. There the tympanic sulcus, the shape of the sulcus varies from anteriorly to inferior, going around. From the posterior and inferior tympanic spines, it goes like that, but towards the 9 o'clock, coming superiorly from inferior, it changes shape from U shape to C shape. The C shape, it is easy to elevate from the 9 o'clock. Then you can gently push the medially. There you can find the chorda tympani also coming out. Just the coronoid keeping on the flap, you can push medially, gently, taking a curved pick, elevating from the annulus. Then you can find the chorda tympani. Without injuring the chorda tympani, you can elevate rest of the things. There you have to change from the pick to the flag knife. While going elevation from the inferior part up to, you can elevate to the 5 o'clock towards in the right ear, up the pars tensa, going to the pars flacida up to anterior part of the head of the malleolus. These are the easier steps to, without damaging the annulus, we can elevate it. Then you can see the middle ear condition. Here we can see the middle ear mucosa is very polypoidal, congested, and also the tip of the malleus. Also there is a bulky tissues are appearing. Difficult with only one hand technique to clear some of the things.
Okay. I'm just trying to, as you have seen that I have used this round knife to clear the debris, because with cotton ball and with irrigation they were not going. They were stuck to the canal. So I just gently, very gently, this has to be done without bruising the mucosa. I just scraped off the debris very gently.
Okay.
It should
very
not,
nice.
it should not traumatize mucosa. So that.
while doing stapedectomy also we have to clean the ear canal twice or thrice.
Okay. I have done irrigation, sir, but the debris are still not going away, so
Okay.
I'm using the round knife. Okay, clear. Okay. So now I will freshen the margins. So I use a curved pick for that. So like Dr. Mohan Reddy said, that you just give interrupted stab incisions and then join them, because it's a one-handed technique.
Yes.
So it's a little different from using microscope where you have both the hands. So with one you have to have some hacks to do this. So if you give interrupted stab incisions and then join them, then it becomes easier. And your incision should be through and through all the layers of the tympanic membrane. So just give stab incisions all around.
Even though after
and the mucosa is little edematous, as Dr. Raidu correctly said, because the patient is saying that he had discharge 3-4 days back. Ideally one would want a dry, and the mucosa should be very pale, and you will not encounter this friable mucosa. So don't be in a hurry. Always see that the patient has a dry ear for 2 weeks at least before you attempt a tympanoplasty, because like I said, that it will improve your outcome also. It makes your work also very easy. Otherwise, if there is active infection, then the mucosa becomes very friable and it will bleed, and you will have a very hazy field, and with an endoscope it becomes a big handicap.
the selection of patient for endoscopic surgery is very most important.
Yes.
It's difficult.
And even the external canal, EAC mucosa also will be very pale when it's free of infection. So all these factors are important, because otherwise when you're raising the flap also, you will encounter a lot of oozing, and with endoscope that also becomes a big nuisance. So please wait, give a course of antibiotics, again give another course, wait, call the patient. If there's any URI, treat that, and then take up the patient when it is ready. Don't be in a hurry, then you'll get a good surgical outcome. Suction please.
If you're reaching this area, it is better to use the iris scissor instead of poking again to prevent the trauma of the rest of the membrane.
I usually use the iris scissor when I'm when I'm raising the flap, sir. But otherwise, can I have the crocodile, please? So I've raised freshened the margins all around. Now you just have to remove the freshened margins. Brother, ఇది soak చేసి పెట్టండి. Wet, dripping wet. And one must ensure that you have freshened the margins completely. You should not leave even a small island of epithelium because you will get residual perforation. So again, this step has to be done. Each and every step has to be done meticulously. So this particular step has to be done very carefully, so that all around you have freshened the margins. You have not left behind any mucosa at all. Because that little area again will not take up, and the graft, you will have a residual perforation. So one must be very careful. It doesn't matter if your perforation becomes a little bigger in the process, but one must always. So now you can see the handle of malleus, and I will denude that. Suction please. Okay, there is some remnant left, so crocodile again. So friable mucosa, what happens is you tend to take out little more than what you would have wanted, because it inadvertently comes out if it is friable. Doesn't matter if you're having an adequate graft.
That is the fibrous support. The principle of doing this is to remove the squamous epithelium grown medially on the tympanic membrane. For that, easily you can use the flag knife end, keeping the behind the membrane. You can scrape it off, and then you can use a cottonoid keep there, and also again you can circular motion, you can clear the squamous epithelium. That is the main principle, to denude the mucosa medially. The medial mucosa should be created like that. Here some of the fibers also.
Okay. So, a little bit here. Okay. So now I will use a curette to freshen, to make the undersurface of the TM remnant raw. You can see the eustachian tube orifice here. This little strand of mucosa is still there. I will remove that. And then I will freshen, curette the undersurface of the TM remnants. It's not catching. Okay, okay. Okay, now you can see the margins have been freshened, but still there is mucosa over the handle of malleus, which I will also have to remove. So can you give me a curved pick again?
Ma'am, aren't you using Savlon for defogging, ma'am?
Yeah, Savlon, or I use wet gauze piece. Mostly I use wet gauze piece. I'm not a fan of Savlon actually.
In the middle ear, better to reduce the use of Savlon.
So
it causes chemical reactions.
I don't use actually, I use only wet gauze piece. Dripping wet gauze piece. So this is the handle of malleus, and now I'm trying to skeletonize it because my graft will be over the handle of malleus. Underlay, but over the handle of malleus. So there should be no epithelium over the handle of malleus. Otherwise it can lead to epithelial pearl, or it can lead to a weeping middle ear. So one must take care to denude the epithelium over the handle of malleus.
Are you going to raise the PM flap, madam?
I will be, sir. I will be doing.
But this can be denuded after elevation of the flap. Now we can have better control.
Yes, sir. I will do that. But normally, I also, whatever is visible, I try to.
Their sickle knife will useful for to elevate from the undersurface and also detaching the membrane from the handle of man.
So this is little difficult for me to do without the micro curette. So I will use again the round knife. Please give me the round knife. Actually, with the micro curette, you can take out whatever little debris or coagulum, unhealthy tissue, granulations, polypoidal mucosa which are present medial to the TM remnants. Because again, otherwise they will lead to post-operative discharge and a wet ear. So you see, all this has to come out. So you scrape it a bit. Okay? Scrape all that unhealthy mucosa. Suction, please. Crocodile. Normal breathing. So now I will do the anterior canal wall flap. Okay. So that is for tucking the graft. As you can see, it's a subtotal perforation. So you need to tuck the flap. So what I do is, from below above, in a retrograde approach, I raise the anterior canal wall flap from 6 o'clock to 12 o'clock.
Can we use the anterior window to pull the graft anteriorly also?
We can do the anterior window, but that's not how I do it. I find this technique a little easy with me. So whatever it suits you, you can do. But this is how I do it. So right from the fibrous annulus, I lift it up to the bone depth. I can feel the bone by scraping it. And I lift it. Because I'm sorry, I apologize, because this case is little, I think, friable mucosa, so it's bleeding a lot, so not very clear to you all. But what I'm doing is, I'm lifting the anterior canal wall flap from the fibrous annulus a few millimeter upwards, so that I can tuck the anterior margin of the graft below that. So come up a few millimeters, like this. Okay, so because this is little friable, so it's bleeding, so it will stop. That will, by the time I put the graft, it will stop. I'll just put an adrenal cottonoid. So please give adrenal cottonoid. Not a very ideal case for surgery, I would say, because he had discharged 3-4 days back. So ideally one would wait for 2 weeks to 3 weeks for the ear to become absolutely dry before attempting the surgery. That would be the most ideal situation. And then you will not encounter this unnecessarily bleeding and all those things. And the field will be clear. Next, I will raise the posterior tympanomeatal flap. Please give me the flag knife again, brother. So, this is posterior, this is anterior, this is inferior, and this is superior. So, I give an incision at the 6 o'clock position, radial, from the fibrous annulus. I come outwards up to the mucocutaneous junction. So you can make out the mucocutaneous junction, and this is the mucocutaneous. This is the skin and this is a mucocutaneous junction. And so this should be incision up to the bone depth. Okay? And so that there is no tear of the flap. So a little bit of to and fro movements are required, and you will feel the grating sensation of the bone even though you cannot see it. That means you know that you have cut the flap to the bone depth. This is important. It will prevent tear of the flap. Okay? So this is at the 6 o'clock position. Now I will do the same thing at the 12 o'clock position. You can see the incision here at the 6 o'clock. So here I make a curvy linear incision. It's not radial. Little curved, curve, so that I can see the incision through my endoscope. I can see the entire incision. So curve, and I bring it up like this. So this is a little modification in the endoscopic technique, which I have kind of found convenient, so I do it. So that's it. Like, so I've curved it. Whereas here I've given radial. So I can again see the entire incision and raise the flap without any difficulty. And again, to and fro movements, I can feel the grating sensation. So I know I've cut till the bone depth. In case of a narrow canal also, this modification helps. We can see the entire incision. It will be in your field. And then with the round knife, I join both the incisions. So this is the superior incision and this is the inferior.
How far from the annulus you will give this vertical incision again?
Sir, just above the annulus only. I mean,
this incision, you are joining the both now. How far?
Joining both I'll be joining here, sir, I'm saying.
Oh,
laterally
this much lateral part.
Yes.
But this much flap may obstruct the view of your scopic view in the middle here?
No, sir, it will not.
The bigger flaps?
No, sir, not at all.
With the microscope, we not come this much lateral. Better to have some small distance away from the
It's not
annulus.
very big, sir. It's only, this is looking magnified like that, but it is not
We
a very
don't
big
advantage
flap.
it for the endoscopic view. Maybe a shorter, I don't know.
You can make a shorter incision also,
Okay,
sir.
okay.
You can make up till here also.
The view entirely differs from microscopic and endoscopic. Okay.
Okay, so I am raising the flap.
Good. Here also tip is to pressure always on the bone, not on the flap. And also keep a small cottonoid soaked in adrenaline and pressure over the cottonoid or on the bone. It easily elevates from the canal
So
wall.
raise the flap. Like I said that if it is not cut to bone depth, then your flap will tear. So when you make the incisions, please ensure
Yes.
that you have cut it through and through. And even when you join at the edges also, see to it that they are joined properly so that
Yes,
there
very
is
nice.
no flap remnant.
Very nice.
So you can see the entire flap in your endoscopic view.
Yes.
And now one thing you must remember when you're raising the flap, that the flap is thick superiorly. So you have to apply little more pressure. Sometimes you need the iris scissors also to cut the flap. But in this case, I didn't need it, but sometimes you may, because the skin is thicker in the superior part. Inferiorly, the skin is thinner, but there will be bleeding inferiorly from the, sir, what is the artery, sir? Which branch of the tympanic, posterior tympanic artery which bleeds inferiorly?
Yes.
So there you have to keep adrenaline cottonoid. Please, brother, cottonoid. This is where it bleeds invariably. In this case, it is not bleeding, but you will mostly encounter bleeding in the inferior part of the flap when you are raising it. So don't panic. Just keep adrenaline soaked cottonoid there for 2-3 minutes, and you meanwhile raise the flap in the middle and the superior part and let this part get decongested. So gently you do this up to the fibrous annulus.
There, some of the equipments also coming with the suction port. These are all the micro instruments coming with the suction port also.
Yes,
To
there are
use
suction,
endoscopic
there
instruments.
are suction elevators also,
Okay.
which are available. You can use them. Okay. Now, can you give me periosteum elevator, please? So here I change to periosteum elevator.
See the cara tympani now, there.
And then here sharp dissection has to be done with a sickle knife to separate the fibrous annulus from the bony annulus. This is also important. And you should do it in the middle, because just below the origin of the cauda, so that you don't injure the cauda. Gently you lift it, tease it out from the bony annulus. That is, you have to lift the fibrous annulus also.
There in the blood we are able to see the cauda going horizontally.
So there is some remnant here which has to be taken out.
Yes, I told you, no, the shape of the tympanic
This is a part
annulus
of the
varies
fibrous
here.
annulus which was leftover, that has to be removed because you cannot put your graft over that. If you put that, then it will lead to weeping ear. No mucosa should be left behind. So I will just use the, give me the crocodile please. Just tease it, gently tease it forward and it will come out of the bony annulus. So you can just use the crocodile and tease off the annulus. Okay? And again superiorly, just hold the flap and just gently tease it forwards. Be very gentle in this step. Don't cause the injury to the IS joint or the cauda. Just tease it forward. Okay, so the entire flap has been elevated now from 6 o'clock to 12 o'clock. Okay, a bit of the fibrous annulus there, you can take it out. And what you see is the middle ear mucosa. And now the IS joint has come into the view.
It also draped by the edematous mucosa. We have to check the continuity of the ossicular chain in these cases.
Yes, yes, everything. So you have to check even the isthmi, whether the isthmi are patent or not. Sometimes there will be some glue or some polypoidal mucosa blocking the anterior and posterior isthmi, which have to be cleared before you put the graft. Then also denude the handle of malleus. I've already denuded part of it when I was freshening the margins, and then any other residual mucosa over the handle of malleus has to be taken out. And this is a cotton ball which I will remove and check for ossicular mobility now. So you can see the IS joint, and then with the curve pick I will move and see the ossicles. So yes, it is mobile, but there is some polypoidal tissue here.
The ossicle means only the nuclear brass is moving. What about the movements of the stapes? Sometimes
Stapes
the
is also
only
moving,
the fibrous.
sir. You can see the stapes also. You can see the mobility of the stapes also.
Yes, yes. Okay. Sometimes.
Look at this is the stapes head.
Yes, yes. In the blood vessel.
And this is the IS joint. So.
Yes, it's mobile.
The entire assembly is moving. And this is the anterior isthmus. You can see it is clear. There is some edematous mucosa around the foot plate. You can just keep an adrenaline soaked cottonoid and see, decongest and see. Also, there is some.
In these type of cases, can you use any silicone sheets to prevent adhesions?
I will remove the mucosa here.
Yes. Cortical
I wish I had a curette.
To find out the aeration pathways.
Brother, no curette. If there is a curette, it would be nice.
I didn't know, but we should see the audiological reports, and also in these type of cases, better to have the CT, HRCT for proper planning.
I'll take out this little bit of tissue here, which is part of the anterior rim of the TM. Okay, and please give me adrenaline so cottonoid. So the isthmi are clear. Only thing is little bit of edematous middle ear mucosa because of the recent infection, but otherwise not much of a pathology. I think it will settle post-operatively with antibiotics. So one more at cottonoid.
Madam,
Whether
what is the
have you-
audiological report of the patient?
Pardon?
What is the audiological report? How much of
Moderate
loss?
hearing loss. That's what Dr. Harsha told me. Actually,
Any CT was done for this case, madam?
I have no idea, Shanmuga.
Okay, ma'am.
Dr. Harsha, if you can tell us.
Yeah, I think Asha is here.
If you can
Dr.
tell us
Sriharsha.
if CT scan was done. One more adrenaline.
CT scan was not done. We don't routinely do for CT.
Nowadays, everything is evidence-based practice, evidence-based medicines. We should take the CT scan to avoid the medical legal issues later on.
Ideally, every
Better.
case CT scan
CT
should be
scan.
done
Yes.
for medical legal purpose and to rule out any sudden unexpected anomalies like a high jugular bulb or anything. You can, like, it's better to be on the safe side, and you just have a few checkpoints and see some kind of any tympanosclerosis or something in the attic, all those kind of surprises which you don't want to encounter intra-op, or you'll be mentally prepared. You should get a CT scan even though it's a mucosal disease clinically. It's always better to get a CT scan, especially in a discharging ear. If it is a ear which has been quiet for about a year or so and there has been no recent discharge, then maybe okay, but still always better if you can afford it, if the patient can afford it, to get a CT scan perioperatively. So I think it's good to go. The bed is ready for placing the graft, and so now you can see the eustachian tube orifice also, a little edematous, but otherwise there's no granulation or polypoidal mucosa.
Will you flush with any Decadron solution?
Yes, we can do that, or gel
Really?
foam soaked in Dexa also. That is something which I keep for some time. Brother, you have dexamethasone drops? Put some gel foam in that and give me.
Or Decadron flush also you can give safely.
Yes, sir. Decadron or dexamethasone drops, gel foam soaked in that can be kept
Injection Decadron.
at the eustachian tube orifice, and that will decongest and reduce the edema post-operatively also. It will give a good outcome. So even during surgery also, what I personally do is, if I encounter some polypoidal mucosa in the peristapedial area, then I put gel foam soaked in dexamethasone drops for some time, and while I work in the other area, and then I come back to it, and once I've removed it, I would have seen that I can actually visualize. So a lot of the polypoidal mucosa becomes flattened out, and if there's any granulation and all, it is easy to remove also. The bleeding is less. So this trick can be used. And also before placing the graft, if there is any residual polypoidal mucosa, you can leave gel foam soaked in dexamethasone drops there. And that will clear out the edema and improve the outcome of your graft. Can I have the flag knife? The round knife, please. The round knife. So there was a lot of bleeding when I was raising the anterior canal wall flap. I want to show it to you now once again. So this is the flap I have raised right from the eustachian tube orifice, and denuding the bone, I raise it anteriorly from 12 o'clock to 6 o'clock.
Yes.
Where I can tuck my graft anteriorly.
Yes, very nice. Here one more point is to packing the middle ear. Most of the times you use the drops. Instead of drops, to have the better control of the gel foam pieces, use the Neosporin H ointment. Here that it takes care of the edematous mucosa also, and also to handle to placing the gel foam pieces easily. You can manipulate. That's why habituate for the Neosporin H ointment. Safely you can use in the pack in the middle ear.
So this is my anterior canal wall, and I will tuck the graft under that. I have made the bone bare. There is no bone here, as you can see. Okay.
It's always better to keep on the bone. The graft will take up easily.
Now gel foam, brother. Periosteum elevator.
Here you have to remember
A drop chain.
ventilatory parts of the middle ear. Ventilatory
gel
parts.
foam
It should be properly functioning, then only the
Dexa kada?
graft will
Oka
take up.
remove
Otherwise,
Dexa.
There
So
should be a
Dexa
retraction
soap
again.
gel foam is what I'm using there. I normally don't use, but little bit of edematous mucosa near the eustachian tube orifice. That is why
Yes.
I'm putting Dexa soaked gel foam there. Otherwise, you can use dry gel foam or antibiotic drop soaked gel foam also. But I use dry gel foam normally. So the first thing
Okay.
is that the eustachian tube orifice should be packed. Okay, that's
Why,
the first
madam?
thing, to prevent retraction of the graft.
Okay. Not all-
Each
retraction
one
is-
has their own technique.
Okay.
So this is what works for me from my trial and error. So that is the technique I'm showing you all today. I'm sure Dr. Raidu will have better suggestions. He's an experienced
No.
otologist, and
No,
also
madam,
each
no,
one
madam.
of you all
Everyone
have
is,
your own.
everyone has their own technique. They have to develop their own
Yes.
technique only.
But
These are the roads to travel.
Yeah, there are many ways to build the cat.
Yes.
So, but whatever works well in your hand. So, and ultimately the patient should have a
The result.
successful
Yes,
outcome dry ear. So I pack with gel foam pieces first. There are people who first put the graft and then lift it up and then put gel foam, but I put it first. Can you please put
For
it
the
first?
anterior-most part is always the better technique.
Yes.
First keep the gel foams, then only keep the graft later. Otherwise, there you don't get the support there.
Yes.
It retracts. That's why. Or
It
otherwise,
retracts.
in microscopically make the anterior window, pull the graft from through the window. It will stabilize as well.
Vestunnandi, brother. So I also use a cartilage, which I'm not showing here, but I
Okay.
used banked septal cartilage, soaked in, preserved in 70% alcohol. And in case of subtotal perforations like these,
Okay.
I put as a scaffold with a V-shaped notch for the ossicles in
Okay.
large perforations to prevent medialization of the graft. I have shown that technique in my YouTube. I have a channel, and I
Okay.
have demonstrated that. If you are interested, you can go to that and see the technique which I have done. So that saves time also. Although medically it is not correct, we cannot, use the homograph, we cannot use isograft, but works well again for me.
If you put the
Preserved
graft, don't
in
mention the
70%
record.
alcohol.
Don't mention the records.
Yes.
Thing.
Okay, sir.
It's a very big crime in Western
Yes,
countries.
we should not mention it anywhere on a public platform also.
Yes.
But like that is what it works well for me. So that is in case of subtotal perforations. To prevent medialization of the graft, I use that cartilage scaffold.
Okay.
So I'm putting gel foam medial to the handle of malleus also. And
You're keeping onlay or inlay, medial to the handle of malleus or the lateral to the handle of malleus? The graft.
my graft will be over the handle of malleus.
Over the handle of
Underlay
malleus.
and over the
Okay.
handle of malleus. That is why I've denuded the mucosa over it. All the epithelium I've removed.
Okay. But
So
it
now
will gone up to
the bed is ready for placement of graft.
Hmm.
So brother, can I have the graft? So just show me. So the graft is, as you can see, it's all irregular, so all the margins have to be trimmed properly. Can you hold the scope? Give me scissors, please.
the fibers sometimes may come with the suction, the graft will come out. That's why you have to properly trim the graft, all the sides
So,
before
Can
keeping
you show,
there.
please?
You have to habituate how to deal with the wet graft also.
No, it's okay. Is it visible to you all?
Yes, yes, clearly visible. You are using the curved scissors to
Yes.
trim the graft edges.
All the irregular margins and
Yes.
fibers which I had teased out. So anteriorly I'm keeping it curvilinear
Yes.
based on the shape of the annulus. And
Okay.
as you can see, it's a rectangular graft. And
Yes.
the width of it will be coinciding with the width of the TM flap that I've
Okay.
elevated.
Yes,
Not
yes.
more, not less, so that the margins don't get folded. And the long thing will lie on
Yes.
the canal, bony canal. So I will give me
You
the...
should know the proper measurements
So
always.
I will hold the anterior end of the graft and curve it like this and just dip it in saline little bit like that,
Hydrating the graft.
and then I will slide it in. I'll ask my assistant to retract the pinna backwards and above. There's a gel foam piece at this end. Gel foam piece this end. Okay. So this is how I will slide the graft. Carefully, right up to the anterior margin, and then. So my assistant, as you can see, is holding the pinna backwards and upwards to widen the canal. So it will be easy for me to slide the graft. And then anterior margin slides all the way down.
Yes.
And then I will change to periosteum elevator. Please, brother.
Nice.
Wet chain. So again, from now on, all your instruments have to be made wet, otherwise graft will stick to it and come out. This is very important. So with the surface tension, so whatever instrument you use, dip it in saline and then put it on the graft. Be very, remember this point. Of course, you all must be doing it, so I'm just emphasizing it. Otherwise, graft will come out.
There you should remember the dimensions of the middle ear space, epitympano, meso, hypo.
So if you take too wide a graft, then these margins will be folded and it will become very messy.
Yes. The proper
so the
size
length
graft.
The width of the graft is very important. Length is not important. Length, of course, if it is little longer also, it doesn't matter. Now I will reposit the tympanomastoid flap, the posterior TM flap, and then I will basically concentrate on tucking the anterior margin, because that is where is it's the site of failure, commonest site of failure if your graft is not tucked well.
Yes.
And so you should pay a lot of attention to that. Check and recheck 100 times until you are sure that the anterior margins of the graft are underneath the TM remnants anteriorly. So as you can see, beautifully that's gone in.
Yes, madam.
I will just show the anterior canal wall flap again. Brother, can you give me round knife? So again, I want to ensure. So again, this is my anterior canal wall flap.
Yes, very nice.
And my graft margins, I will see to it that it is brought up and then it's just underneath that. So easy technique. The other way is like Dr. Raidu said, that make a pocket here, like that. With this knife only you can make a pocket here up to bone depth and then raise the flap downwards, like anterograde. I am doing it retrograde. So you can do that and then pull the flap through that. But this works for me, like it's easier for me. Because one-handed technique, so we are all one-handed surgeons, endoscopic surgeons. Whatever we can do with one hand, we should do.
Yes,
because you have to hold the endoscope with the other hand.
Okay, very nice, very good demonstration.
So and then again see, check and cross-check. Check and cross-check is what I'm saying. You cannot overemphasize this point. Each and every tiny millimeter should be well seated and tucked well. Spend some time because you're giving lifelong result. Don't be in a hurry. There's no competition to say that, oh, I did it in half an hour, nothing of the sort. You're giving lifelong result. So whatever you do, do it meticulously. Pull up the graft.
Okay.
Pull up nicely and see that the margins are not folded. They are tucked well.
Will you place the gel foam again medially?
Medially I had put, sir.
So
deep to the graft.
There the sufficient, the space?
Sufficient means, yes, I think so, sir. See, it's because it's coming under the graft now, the TM flap, so I think it is okay. Then I will put gel foam here also.
Yes.
And that will bring up the graft a little bit.
Yes.
And then again, using the back of the flag knife, I am trying to push the flap back to so that it sits in the bony annulus. And there is no blunting of the margins and the graft is not lateralized. So with the back of this instrument I am doing that. Okay, that's it. And then ironing out the flap also so that there is no folding.
Okay.
All good. And next I place gel foam. again while putting the gel foam, I put small gel foam medially and then I put larger pieces out as I come outwards. Again, I'm wetting the instrument every time so that
Here, the placing
every
the
time
gel
I'm
foam.
wetting, I'm using the periosteum elevator, I'm asking brother to drop the gel foam pieces and I will put them. Brother, please drop the dry gel foam. So some people use dry, some use antibiotic soaked, I use dry.
Yes.
Because I have seen that in a few cases, I'm getting otomycosis, especially in summer and all because of humidity and sweating. If I use antibiotic soaked gel foam pieces, then the patient is getting otomycosis. So I generally prefer to use dry gel foam. And
Here's
small pieces, first anteriorly,
Okay.
to prevent any blunting of the margins of the graft, small pieces.
Here also you can use the small gel foams, compressor gel foams, compressor dry gel foam over the edge of the neotympanic membrane or the remnant of tympanic membrane. It holds tightly, acts as a scaffold.
Keep dropping.
All the edges to be covered with the compressor dry gel foam. It acts as an anchoring part. Then you can use whatever later on.
So there are people who trim the ear canal hairs or use a hair removing cream. All that is actually not required once you get used to using the endoscope. It's a matter of using it and in the right angle. And the advantage of endoscopic technique is that even if your canal is narrow and there is an anterior canal wall bulge, you don't need to do canaloplasty, you can negotiate the corners. But only problem is if it is narrow, then your instruments keep touching the canal and there will be some oozing, especially the suction tip and all. So like Dr. Mohan Reddy said in his lecture, that you should not traumatize the canal. Little one drop of blood also, there will be a lot of oozing and then that blocks your view. So in that case, again use adrenaline soaked cottonoid for 3 minutes and keep it in the canal, have little patience, work in another area and then come back. Then you will get a dry field again. But don't operate in a bloody field because it becomes frustrating then.
Very nice demonstration, madam. Very good.
Thank you,
Please
sir.
give an applause, big applause from the auditorium.
So it's a big thing
Thank
for
you.
me. Compliment coming from you, the great
Yes,
otologist.
No,
I'm a
no,
big
no,
fan
I am
of
not
yours,
great
sir.
at us. I am simply doing
No, sir,
surgeries,
no,
that's
sir.
all. The
I
endoscopic
think
surgeries,
in South
really, really good. Even though it is a
marvelous cochlear
congestive
implant
mucosa.
surgeon, a great otologist. Thank you, sir. It's my honor that my surgery was moderated by you. In fact, this is the very first live surgery I'm doing in a conference, thanks to Harsha. Thank you. I feel really honored. My very first live surgery demonstration. Till now, I've been only doing YouTube videos. So those interested can, look up my YouTube channel. I have posted a lot of endoscopic tympanoplasties. And so you can just revise the steps there. This is a self-learning for me. Unfortunately, I didn't have a mentor in endoscopic middle ear surgery. It was just by trial and error that I kind of designed what's best for me. It took me a year to learn endoscopic ear surgery, and I do endoscopic stepidotomy also. I find it very easy, and limited cholesteatoma also with endoscope, and hybrid method for extensive disease. But ultimately, I come back to the endoscope when it comes to visualizing the middle ear. You can use angle scopes also if you have narrow canal, or if there is any pathology in the posterior isthmus which you encounter during tympanoplasty, and you can very patiently use curved suction tips and angle instruments to remove the polypoidal mucosa or glue. You don't have to actually resort to cortical mastoidectomy. So don't panic, just visualize and take out pathology. And the results will be very good. So there are many people who don't use any pack, only gel foam, because again pack can cause infection and post-operatively otomycosis and all those things. So just gel foam is enough, gel foam packing. Use bigger pieces as you come outwards. And then of course pressure dressing over the graft area, that is a suprameatal area, that is very important. I do a mastoid dressing and keep for 1 week. to prevent any hematoma formation. And in the middle ear outer part, we use a cottonoid soaked in soframycin. Brother, can you give me that? A long cotton soaked in soframycin. I pack the canal completely with gel foam. Only in this part, I put a soframycin cotton ball. And then a mastoid dressing. Yeah, I send it. So thank you, everybody. If anybody has any questions, you can please feel free to ask.
Ma'am, we'll take the questions little later in the auditorium. So moving on to the last topic for the conference, I would like to introduce my friend, Dr. Kashyapi. She is the allergy specialist in our center. She visits frequently from Chennai. And it's a short talk on allergy, then followed by a live demonstration of skin prick test on a patient. So anybody interested, you can come and watch. Of course, it will be relayed on the screen. Thank you.
Thank you, Harsha, and congratulations on the setup. Thank you for having me. I won't take much of your time. I'm sure everyone is exhausted with the very extensive laid out surgeries for the past 2 days. So I am here only to bridge a little gap that every one of you, I'm sure, must have faced at one point or the other, especially post-surgeries or post-dealing with multiple allergy cases in your ENT OPDs. So here I'm trying to focus a little bit of why an allergy surgeon, ENT surgeon should have little bit knowledge about allergy. If not practicing by themselves, at least have a little bit of knowledge about it. Just a basic thing of what exactly is allergy. Again, everyone knows what allergy is. It is basically overreaction to substances which are from the environment, which are actually harmless, but they do induce an immune response and cause variety of symptoms. So the maximum types of allergies that we generally know are respiratory, skin, food, and others. What we deal with on a day-to-day basis will be mostly respiratory, that is upper respiratory. So allergy is definitely a chronic disease. The burden of it is actually unseen. It is actually the tip of the iceberg, what we see with regards to allergy. But overall, it affects the quality of life of a patient and even a doctor, because the patient keeps on coming to you multiple times. All you do is keep on changing the antihistamines, keep on changing the nasal sprays, and that's it. So there is extended set of evaluation which the patient can be taken up for if you know just a little bit of allergy background. So the burden as such, I'll brush through very quickly. Close to 400 million in India, very high burden. We take it lightly because all along the training for us has been allergy is simply an antihistamine and a nasal spray. That is not how it is. Allergic airway diseases, if you see, only in upper respiratory itself, if a person is having a long-standing allergy, we'll have comorbid sinusitis, they'll have serous otitis media, there is tubal dysfunctions, they have conjunctivitis, viral infections which are predisposing the allergies, and adenoid hypertrophy, nasal polyposis, especially all of you must be very much aware of the sinonasal polyposis, which keep on recurring and recurring. You need to give some answer to the patient, right? So that is what allergy is here for. So especially in an ENT clinic, how we encounter allergy is directly through nose. It is allergic rhinitis, which is obviously known, it's our bread and butter. Next is rhinosinusitis, allergic rhinosinusitis. You see frequent prescriptions, ARS is what is written. It is allergic rhinosinusitis. That is the second most common entity. Okay. So the next one is allergic laryngitis, especially singers end up, of course, vocal nodules are something which the surgeons take care of, but allergic laryngitis is also a very, very common complaint. The next one is allergic otitis media. You place a grommet, you do everything and whatnot, but then if you're not treating the root cause, the underlying cause, it will still keep on happening. The pathophysiology is still occurring inside the body. And last but not least, allergic rhinitis and bronchial asthma. Our constant tug of war with the pulmonologists is we send you for cough, you send us back with a inhalatory corticosteroid. So instead of seeing it as a different entity, if we can combine it together and try to see it as a united airway disease or a single disease, that is much easily tackleable than sending to a pulmo separately, sending to an allergist separately, sending to an ENT surgeon separately. So out of these, the most common things that we encounter are allergic rhinitis, nasal polyposis, and serous otitis media with effusion. Just a very, very basic about what an allergen is. Allergen is actually, we call it as an antigen when we are testing it, but allergen is any substance, most often inhaled or taken in orally. So that is recognized by the immune system, which causes an allergic reaction. So generally, we tend to call these allergens as proteins. So they are relatively small proteins which are 5 to 100 kilodalton in weight. And most cases, they are water-soluble allergens in general. So if you see several allergens, they directly interact with the mucosal tissue and cause the respective symptoms per se. So why is an allergy caused? There is a mismatch, there is an imbalance between the Th1 and Th2 hypersensitivity that is happening. If there is high Th2 phenotype that is predominant, that will lead to allergy. So there is a small concept between sensitization and allergy. Since we are talking about a live patient whom we have, we'll be doing a prick test, you need to know only this point, what is sensitization and what is allergy. Sensitization is just that a positive skin prick test, which we'll do right now, or a blood-based test, which I'm sure many of you have encountered by now. That doesn't prove an allergy. It just says the patient may be sensitive to it. But if it is correlating with his symptoms, apart from the clinical presentation and apart from the prick testing and the blood workups, if everything put together is correlating, then that is allergy. So the mainstay of focus over here when an allergy patient comes to our OPD is history. I know we are tired of taking histories in ENT. It's all about chop, 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 go keep on doing surgeries and stuff. Here, I think you have to get back to your basics and spend a little time on taking a very detailed history. That way, it makes your practice very easy. The patient is definitely stuck to you. Right, so this is again, we face it, I don't know how many times in a day or in a week. So is it common cold, it is allergy, is it sinusitis? That is something which we will never be able to classically differentiate, but there are certain small clues that we can take back from few presenting symptoms where we can say, okay, this may be sinusitis, this may be allergy, this may be cold, depending on when it is coming, depending on the associated features. For example, if it is sinusitis, they may be having facial pain, which you're already aware of. Atopy, history of atopy in the family. Generally, sinusitis may or may not be a very strong family history of atopy. But if it's common cold or if it is allergies, there may be, strong history of atopy. So these are smaller things just put up in brief to give you a, overview of what all you can ask the patient. So just concentrate on the symptoms and sign. If there's watery eyes, anything with regards to allergy, not just nose, concentrate on the throat and ophthal section as well. Coming to the common allergens, there are, as I said, it's either aeroallergens that is spread by air or food allergens, that is, you consume it. So the most common aeroallergens, if you see, are dust mite. The very, very common phenomenon, dust allergy, I have dust allergy. So it is dust mite allergy rather than the dust allergy. There is a living organism which is producing the dust particles. That is called the dust mite. Right. The next thing is pollen. The other one is animal dander, mold, fungus, or whatever, and cockroach. These are the predominant things that we encounter in India. And food, the commonest things in food are egg, fish, peanuts, rarely seen in India, but it is picking up because of the westernization that is happening, and shellfish. These are the most commonest food allergens that we come across. So this is just a brief, I'll quickly skip. What happens in a dust mite allergy is the dead skin, our dead skin, indirectly feeds the dust mite. It becomes the food for the dust mite as such. So the dust mite, this is the dander, this is our dead skin. It grows in humid, very humid conditions, and that is eaten up by the dust mite. The mite releases its droppings, which is settled in multiple places all around the house, especially in closed doors. We have a feeling that you go out and you're exposed to dust. No, that is not the culprit here. The more indoors you are, the worse it gets. So the dust mite droppings are present in carpets, textiles, upholsteries, our mattresses, pillows, and cushions, and everywhere. That is where the ultra fine dust particles, have you ever tapped a mattress and seen very fine dust particles and tried to catch it? I'm sure everyone must have done in their childhood. Those are the ones which are causing us a long-term problem, even for the patient for that matter. So this is a never-ending cycle. So as long as we are there, the dust mites are also going to be there. So how do we establish, since we are talking about IG mediated only, I'm not going to depth. Again, as I told you, history is very, very important. Please ask the timing, the duration of symptoms, how frequently are they occurring, the family history, how are they getting controlled, all that becomes a very good history. Along with clinical suspicion of allergy. Yes, after taking history, you are suspecting the patient to have an allergy. Tests, whatever we are going to suggest or going to do, will support our diagnosis. 50% of the job is done in allergy once you take history itself. That's more than enough. But then you have to substantiate, as sir has just told this, we are in an era of evidence-based medicine, right? So you have to have a proof for everything that you tell it out. So that is where tests will help. What are the tests that so the main agenda is, say for example, there are 4 people, all 4 of them may have allergy, but we have to find out who actually is suffering. Just because they have an allergy doesn't mean they are subjected to the test, right? If it is interrupting with their day-to-day activities, if they are suffering, that is when you pick them up, you select the patient appropriately for the test, and then interpret the test. So this is a diagnostic pyramid. This is how we approach all the patients of allergy. We go from top to bottom, bottom to top. Bottom again is medical history and physical or clinical examination, followed by the in vivo diagnosis, that is skin prick testing and intradermal testing, patch testing, whichever is applicable. I'll be dealing with skin prick testing today. In vitro diagnosis is serological testing, that is serum-based total IgE, specific IgE testing, component resolve diagnosis, and all that. The last thing is organ challenge, that is either nasal provocation testing, conjunctival provocation testing. If all of these are failed, then that is something which is the tip of the pyramid. So amongst all these, I have then again classified separately. What do we choose? What is the ideal thing that you want to choose? If you are a very busy practicing ENT surgeon, all you can at least do is probably do a skin prick test. Keep 1 day for your as an allergy clinic, and then start doing skin prick tests. That's the easiest thing, because that gives you gives the patient also a lot of feedback immediately. Because collecting a sample, sending it somewhere, the patient doesn't see what is happening. There's no immediate feedback from the patient as well. In the practice, what we have seen, a skin prick test gives excellent outcome from the patient's end. The patient trust is also built, and the results are pretty instant. That's one of the reasons why, in spite of modern techniques being invented, skin prick test still stands to be the gold standard for diagnosis of allergy. Right, so this is just a position paper which is given by the European Academy, which is supporting that skin prick test is still the gold standard test, as I already told you. So what is the principle of an allergy testing? There is small amount of allergen, less than 0.001 ml is taken and introduced placed onto the epidermis, and then on a non-vascular area. So wherever there is less vascularity, you place it either on the forearm or on the back of the person. You place that, and and you do a small scratch. Once you do a small scratch, there is a histamine and other mediators which are released, which will cause a wheal and a flare reaction. Depending on the patient's skin tone and depending on the severity of the allergy, you may either get a wheal or a flare reaction. The depth of pricking is very important, approximately around 0.5 mm with an angle of 45 to 60 degrees. The reason for having that angle is you don't want to go too deep and cause a bleeding over there. All right. So again, as I told you, history is very important. Need to know about what all, because see, example, you encounter a person, you are doing a skin prick test set of testing, the person doesn't eat meat at all or shellfish at all, and then you do a test, it comes positive. You are forced to answer the patient why it came positive and why you tested also. That is why go from history. If the person doesn't eat meat or shellfish at all, either skip doing it or have a substantial evidence why you want to do it. All right, fine. So specific IgE, again, specific IgE is something which is the next step of skin prick test, wherein after the gold standard skin prick test, if it is no clarity with regards to that, then we skip to specific IgE. This is generally the freely circulating specific IgE antibodies which are in the serum. So they specifically target, so if you are allergic for tomato, say specific IgE for tomato or specific IgE for egg, that is how specific we test with regards to specific IgE serum testing. So why exactly are we worried about allergy? Why do we need it? Plain and simple. Anyway, we are going to give an antihistamine. Why are we worried? We are worried because it's a progressive disease. An allergic rhinitis, if left untreated, will end up into an allergic bronchitis and even an asthma at a later point of time. I'm sure you must be having many colleagues, especially in pediatrics, where they'll be saying, oh, less than 5 years? Okay, you'll outgrow allergy, don't worry. After 5 years, you'll be fine. Once you start going to school, you'll be fine. But I'm sure in most of the cases, even you would have experienced in your day-to-day practice that there are still people who will never overgrow and who are forced to be on medications for a very long time. Because allergy is a progressive disease. And what we can do is, if there are any avoidable allergens, we can at least tell them, yeah, okay, stop, avoid this. This is what you're supposed to do to avoid. But if there are non-avoidable allergens, which is the root cause for the allergy altogether, you can start treating it. There are treatment options. There are proven, with scientific evidence, proven treatment options, something called as allergen immunotherapy. I'm sure every one of you must have heard about it. So planning the pharmacotherapy and planning the immunotherapy is what is very, very important, and that is why we need to evaluate and dig deep into allergy. So what are the indications for allergic, skin prick test, you say? Allergic rhinitis, which is the first and foremost indication, along with rhinosinusitis, conjunctivitis, asthma, food allergy, any oral allergy syndromes if they are present. All these will become the basis for the indications. Where is it not indicated? If there is a chronic urticaria which is happening, if there are migraine issues, only that is the only primary symptom, then don't take it for skin prick testing. If there is only irritants, say if the person comes and tells you I'm allergic to, say, perfumes, there's nothing that you can do, it's just an irritant. The person comes and tells you I'm allergic to agarbattis or petrol or something like that. These are all irritants. We can still avoid them at any point of time. So don't test for all those stuff. The absolute contraindications are, as such, you avoid absolutely in severe dermatological conditions in multiple cases. And if they are having anaphylaxis episode, immediately after anaphylaxis, please avoid any skin prick testing. Again, I keep on insisting, you see a history slide quite often in my presentations. The reason is it is very, very important. Use of standardized extracts to test for allergy is again very, very important, because that gives you ultimate excellent results. How many are we supposed to test? How many allergens are to be tested? That is something which is important. Based on the history, choose how much ever is suitable for the particular patient. Right. So this is a small, guide for you on how to choose your allergens for a skin prick test. I know this is a lot on this day, but just trying to give you an overview, that's all. Say for example, the patient is having rhinitis and rhinoconjunctivitis. If the symptoms are sneezing, running nose, etc., but happening only seasonal, that is during the switch of the season they're having symptoms, try and assess if it is a pollen-induced allergy. If it is happening all through the year, irrespective of be it January or March or May or anything for that matter, try to put your finger on a house dust mite related. HDM is house dust mite related allergy. And if it is only seasonal with perennial symptoms, that is it exacerbates during very cold or wet seasons, that is then you have to think about mold as well. Just a simple guide based on history how you can choose your allergens also. Right? So what do we choose? You can ask me, why do we have to take so much pain in taking the histories, doing the skin prick test and all that stuff? Why can't we just send it across to a blood test and get the job done? See, it's all about, ultimately when the patient is paying from the pocket, it's all about cost. Expense-wise, specific IgE testing is much more expensive in comparison to a skin prick testing. Skin prick testing, it's in our hands. We can choose how many ever we want to do, but it's lightly expensive. I'm not saying it's bad. It is good in a way, but it is quite expensive. Apart from all this, we don't need a very big expertise to do a skin prick test. All you need to have is probably a few weeks of training, and then you're good to go. Whereas this one, you need to be associated with the lab, send it across. You need to know what test has to be sent and all that stuff. So that leads a lot of thinking on the spot and all that stuff. So just a few comparisons between specific IgE and skin prick test testing. So this is a small treatment algorithm of how to manage allergic rhinitis alone. So a step-up therapy if it is poorly controlled from left to right, if you see. So the allergen avoidance and the parent and caregiver education is there in every step. So right from the initial step to the terminal step, that is always there. If possible, please avoid. But immunotherapy comes up in the topmost part. That is, you have added oral antihistamines, you have added systemic antihistamines, nasal steroids is done. Still there is no relief. They are not able to stop the pharmacotherapy, or even if you stop, they are forced to restart it. That is when we need to dig deep and then consider a possibility of immunotherapy. Again, what does immunotherapy do? It converts the Th2 into Th1 responses. It produces the interferon gamma and prevents production of IL-4. That is basically the mechanism that happens in immunotherapy. So it is not rocket science when it comes to immunotherapy. In short, for layman language, it is nothing but allergy vaccine, or a short for allergy. That's all. A vaccine for allergy, a permanent cure as such for allergy. Right, I'll just skip this part. Just a small note on what is the role of nasal polyposis and role of allergy in it. So there are multiple studies which have shown that the most common cause of recurrences in nasal polyp, fungal, non-fungal, doesn't matter, but recurrences of nasal polyp is the history of atopy and the predisposition to severe allergy that is happening. So what they have done is multiple studies. They have seen that the incidence of 50% of allergy in patients with chronic rhinosinusitis with polyp patients. So that is why they have also shown that allergic rhinitis and chronic rhinosinusitis, they are comorbid conditions. They exist together. So if you are able to catch the culprit antigen and either avoid it or treat it, maybe you are providing a good option for the recurrent surgeries that are imminent for that patient. Again, the prevalence of allergic rhinitis and chronic rhinosinusitis depends on the phenotype. Again, we are in a very modern era wherein we are not stopping with phenotyping. We are going for endotypes also. That is the depth at which we are going. We are going chronic rhinosinusitis with polyps, without polyps, with endotypes, without endotypes. Why we need to know all these is the chances of working of surgery, the chances of working of immunotherapy, or the chances of working of pharmacology. If we are clear, it reduces a lot of burden on the patient also. All right. So just evidence that I wanted to give you. This is again a European position paper which was released in 2020. Role of biologicals. This is something which I'll end my talk with. I'm sure this is coming up to a large extent. Our fellow pulmonologists are following, and they are taking up all our cases also, mind you. Okay. So what is happening is we are sitting and we are trying to give relief to the patient by giving surgeries, by doing surgeries. But then multiple surgeries, the patient is also vexed, right? But biologicals are amazing tools when it comes to nasal polyposis. And this I'm telling not just out of patient experience, from personal experience as such. Unfortunately, we still don't have the proper biological to treat the nasal polyposis, which is the dupilumab, that is anti-IL-4 yet. But we do have a better biosimilar one, which is called omalizumab, which is still helping. I would ask and encourage all my colleagues and seniors over here to try and use it, because that is something which is approved in India, and the best part of the patient is it is it is covered under their insurance package. So if you have a patient whom you have made to undergo surgeries twice, thrice, 4 times, and there is no relief, try a trial of MABs, any MAB for that matter. Mepoli also is working very well, but as basic as omalizumab also works well. So that is why I have mentioned the present and the future of nasal polyposis. The present is we are giving nasal sprays, we are doing sinus surgeries. What is the future is giving anti-IgEs, giving anti-IL-4s, anti-IL-5s, etc. Right. So we'll thank you for your patience, by the way, and we'll just go ahead with the so we'll just go ahead with the live demonstration. We have, sorry, I didn't get your name. Sorry? Abhinay. So we have Mr. Abhinay with us, who's generously accepted to, help us out. So I'll just be doing a very quick prick testing on him. So before that, I have taken his history as well. So his history is pretty much with regards to allergic rhinitis. He's been suffering since he's joined, coaching, long-term coaching for +2. So for almost four years now, 3 years now. Yeah, so his main symptoms are he has a running nose, sneezing. He doesn't have any loss of smell or something, but his symptoms are mostly perennial. That is all through the year. There is no variation with the climate or not. So I would rather stick to doing only, prick test for aeroallergens. That is mostly dust mites, pollen, because he's lived in multiple places. He's lived in Vijayawada, then he's now in Hyderabad. The symptoms are pretty constant everywhere. So dust mite is my main, point to be noted. But I would also like to check for a couple of, pollen and also fungus. So this would be my ideal choice for doing a prick test. What I will do is I'll just start the prick test and then just guide you through the course. Just give me a minute. Just a tiny drop, not even a big one, just a tiny drop, and make a scratch. So I'm just marking his, I've already cleaned the hand, so I'm just marking his all of you can come closer if you want to see. I'll be more audible, I believe. we lack in India, not because India is anyway backward, we lack it in India because, allergy is something which is not taken very seriously earlier in India. Now they're taking it seriously. Earlier it was mostly, as I told you, an antihistamine based treatment. So now I'll be taking something called as a lancet. So this is histamine I already placed. I didn't? Oh, sorry. So this is my positive control, which is the histamine. So I've already placed it. And again, when in a country where the resources are of utmost importance, we use a single lancet for all the antigens. Make sure you wipe the lancet after every prick. Noppi undadu, just a chinna scratch chestanu. Okay? So this is what I do. That's it. It won't be painful. Ideally, when you're doing it properly, not even a single drop of blood is generally visible, right? So yeah, I lift the skin. If you can you, I don't know if you can see, but there is a small bit of skin. I'm still holding the skin, right? So angle of 45 to 60 degrees, depth around 0.05 mm. So this is what is skin prick test all about. So as I told you, technique matters. The more you practice, the faster you get the hands-on on this particular technique. No, ma'am. There's no control as to if it has to go entirely or half. It is just that you have to prick and lift. That's all. Even this prick and lift concept is being obsolete right now. Right now, it's all about making a small scratch. Sorry, making a small scratch in the uppermost part, in the epidermis especially. So that is why the safety profile of this is so safe that the least age that we can do this is for even a 2-year-old. Okay, we have done it for even a 45 days old, but that is only for special on request basis. But the least that we can do, the protocol wise when we see, least we can do is for even 2 years and above. Okay.
Does we use the same lancet?
Sir, we wipe it in between. So what we have done a lot of studies on this. Even if we use the same lancet or a different lancet, it doesn't matter. So as long as you wipe it properly, there is no cross contamination between each antigen. It is more than enough. The only thing is histamine is something which we do at the end, because histamine is what is our positive control. You don't want that contaminant to cross to the rest of the things. So saline is something which I've done first, and histamine is what I've done next. So this is pretty much complete. No, ma'am, I've done it. Oh, I didn't place it up. Sorry, one second. So since I've used this for histamine already, sorry, I won't be using the same lancet. I'll be using a different lancet. So once I've used a histamine lancet, I won't be repeating it.
లైవ్ ఇంటి కొడుతున్నాను నేను